Thank you. Assalamu alaikum everyone. It would be nice if you would please be seated. Assalamu alaikum everyone. My name is Dr. Rafifa bint Irfan, and before anything else, I would like to congratulate all of you on the successful inauguration of the Global Health Security Summit 2024. Without further ado, I would like to welcome you all to the first technical session of the Global Health Security Summit, which is the Pandemic Preparedness and Response. COVID-19 has underscored the critical importance of pandemic preparedness and swift response strategies. The global impact of the virus has exposed vulnerabilities in public health systems, necessitating a re-evaluation of international collaboration, resource allocation, and crisis management. Engaging in a thoughtful discussion on pandemic preparedness will allow us to learn from the challenges faced during COVID-19 and collectively work towards bolstering our ability to respond effectively to the future global health threats. It is now only pertinent of me to introduce the esteemed moderator of this thematic area. It is now only pertinent of me to please introduce the esteemed moderator of this thematic area, who is Dr. Rana Muhammad Safdar. Having previously served as the Chief Epidemiologist at the National Institutes of Health, Dr. Safdar is currently providing strategic guidance to the collaborative projects of Integral Global and US Centers of Disease Control in Pakistan. He is a medical doctor, public health specialist, and a field epidemiologist with highly specialized training in emerging infectious disease epidemiology from the University of Iowa, as well as the health metrics and evaluation from the University of Washington, USA. He has led the development of the country's successful COVID-19 surveillance and response system, and he has also served as the Director General Health of the Ministry of National Health Services, Regulations and Coordination. I would now request Dr. Safdar to please take the floor and introduce the panelists and elaborate the sub-themes as per the agenda. Please, sir.
Thank you. So I hope I am audible for the colleagues sitting in the back. Thank you so very much. So, Assalamu alaikum and very good afternoon to excellencies, colleagues, ladies and gentlemen. Just before lunch, we heard about the commitment of our leadership, and we were really fortunate to have the participation from actually quite wider geographical region, multiple state representatives, they were there, ambassadors, they were also there. Now, I think having heard that unprecedented commitment, it's time to start our technical discussion. And for this first session, which is on pandemic preparedness and response, we have a galaxy of experts available with me, and now I'll be introducing them to you, and I'll be requesting my panelists to take their seats as I introduce them as well. So, just to begin in the order of the agenda that's available with me, I'm going to request Dr. Ian Wilson to take his seat on the stage. Dr. Ian brings 3.5 decades of experience in public health and communicable disease control. Ian was the IHR strengthening project country lead for Pakistan, so many of the colleagues, they might have already interacted with him during the 2016 to 2018. And during this point in time, he worked very closely with our federal and provincial colleagues for the development of the integrated disease surveillance and response system. Ian returned to UK in May 2018 as the Asia portfolio lead to begin with. And in 2021, she became the IHR Strengthening Project overall lead. And now she oversees a team of over 20 UK-based and more than 50 in-country staff in Pakistan, Indonesia, Thailand, Zambia, Nigeria, Ethiopia, and Africa CDC. Ian Wilson, will you please join me on the stage? Thank you. So next on agenda is again my friend and colleague Richard Brannan, who is the WHO Regional Emergency Director for the Eastern Mediterranean region, based in Cairo. So in this capacity, he oversees support to the 22 countries for emergency preparedness, detection, and response. Before this, he also spent actually quite a significant time at WHO headquarters, and there his assignments included Director of the Emergency Operations, Director of Ebola Response and Coordination, and Director of the Humanitarian Response. Rick has extensive experience in emergencies over 40 countries across Africa, Asia, Eastern Europe, and the Middle East. His vast contribution to advance global health emergency preparedness and response also include leading the development of WHO emergency response framework. Rick, will you please join us on the stage? Thank you. Thank you. So my next speaker is Dr. Elizabeth Hess, who is the Program Director and in the Division of the Global Health Protection, and also the Acting Country Director in CDC's Pakistan office. She is basically an EIS officer by training and worked in Immunization Safety Office, has 15 years of experience in preventive medicine and public health physician with over 20 peer-reviewed publications. She also has extensive experience in public health capacity building and emergency response during the Western Africa Ebola outbreak, COVID-19, Afghan resettlement, and Southern Africa wild-type polio outbreak. So, Lisa, would you please join us over the stage? Thank you. So next on my list is Supriya Madhavan. She is the Senior Public Health Specialist in the Global Financing Facility for Women, Children, and Adolescents at the World Bank. Her technical portfolio includes demography and population change, sexual and reproductive health and rights, and high-quality health systems. While she currently works on Afghanistan and Pakistan, she also possesses deep professional experience in sub-Saharan Africa, Southeast Asia, and the Balkans, as well as in the fragile settings and humanitarian relief besides the health system strengthening. Supriya, would you please join the panel of the stage? Thank you. So my next speaker is Professor Dr. Mahmood Adil. Dr. Adil is a healthcare leader with 30 years clinical and public health, academic, and executive management and policy experience. He has served on key senior positions in UK, USA, and Qatar, covering areas of health protection, including One Health, health intelligence, health innovation, healthcare planning, and regulatory functions. In 2021, His Excellency, the Minister of Public Health for Qatar, appointed him as National Advisor to excel and transform the healthcare system in Qatar. So Dr. Adil, would you please join us on the stage? Thank you, Adil. Next, I am going to request Dr. Rehana Ahmed, who is a medical doctor trained in Pakistan and UK with an executive MBA from Columbia University. Her career has been focused on maternal and child health. She is founder of social franchising in Pakistan, and she also had the opportunity to propagate this social franchise model called Blue Star and Green Star franchises for international NGOs in several countries. She also assisted the German Government Development Bank in the design of output-based aid voucher program, and at the UN, she was the reproductive health specialist for Millennium Villages Project for East and Southern Africa. Dr. Rehana, would you please join us? And last but not the least, again, my brother and colleague, Abdullah Fadil. In Pakistan, we all know him as a long-standing friend of Pakistan. He is currently the country representative of UNICEF since June 2022. He brings over 25 years experience of dedicated work in international development and humanitarian relief, strategic management, peacemaking, peace building, public policy and administration, and advocacy work. He previously served as the UNICEF representative in Sudan, but he has also served with the Department of Peacekeeping Operations at New York headquarters, as well as with various field missions. Dr. Fadil, would you please join the panel on the stage? Thank you so much. So now with all experts here joining me over the stage, without further ado, I'm going to request Okay. So there is some technical hitch, so I'll have to change the order of the presentations. So I hope my next speaker on agenda is also all set to deliver his presentation. So we are going to actually take start from Rick Brennan, who is going to talk about all hazard risk characterization and communication, and particularly to know the risk profile and risk mitigation. So Rick Brennan, over to you.
Okay, great. Thanks very much, Dr. Rana. It's very good to be with you all. And I was only thinking this morning, I've been coming to Pakistan for 25 years now. My first visit here was in 1999, so always a pleasure. I do have some slides. I don't know if they're going to be projected. But while we're here talking about the Health Security Summit, we're primarily going to be focusing on our remarks over these couple of days on infectious risks and infectious hazards. But Pakistan knows, as well as any country, that all communities, all countries are prone to hazards from many different causes. And so when we are planning and preparing for emergencies, there are some commonalities that we have to, in our preparedness and in our response activities that cut across all hazards. And therefore, we also need to be assessing for the risks of the various hazards that may present themselves. So, for those of you who aren't familiar with WHO's Eastern Mediterranean region, we cover 22 countries from Morocco in northwest Africa, across most of North Africa, Sudan, Somalia and the Horn of Africa, across the Middle East as far as Afghanistan and Pakistan. It's one of the most emergency and disaster-prone regions in the world. Right now, there are 9 countries of our 22 that are classified as fragile or conflict-affected by the World Bank. 13 of our countries have major impact, either direct or indirect, from conflict, including Pakistan hosting a large refugee population. In fact, the number of people needing humanitarian assistance in our region has more than doubled since the start of the pandemic in January 2000. And most of that increase in humanitarian need has been driven by conflict. In addition, the region is very prone to natural disasters. And if you only look at what's happened across the region in the last 12 months, we've had a massive earthquake in Syria and Turkey. We've had earthquakes in Morocco and Afghanistan. We've had the major floods and dam burst in Libya, major food insecurity in Somalia. So, and of course here in Pakistan, very prone to natural disasters, including the massive floods back in 2022. And I was here in 2005 following the major earthquake. So given that complexity of risks and hazards, how does any organisation or government organise itself to be able to prevent, if possible, mitigate, prepare for, detect and respond to emergencies from all hazards? Well, I'm going to talk in a moment about our approach to risk assessment, and I'd appreciate it if the slides could be projected, because I think that they'll be helpful for us all to follow. But I do want to talk about, with that complex array of risks and emergencies, WHO, we've invested a lot in strengthening our capacities in emergency management. Now, emergency management, it's often underappreciated, it's a standalone profession in many countries with its own qualifications, its own standards, its own best practices. And within public health, emergency management can be considered a key subdiscipline. And we have invested in building broad emergency management capacities and around some basic key principles. Having a comprehensive approach, and by a comprehensive approach, I mean working through all phases of the emergency management cycle, from prevention and mitigation, preparedness, detection, response, and recovery. By having an all hazards approach, because again, all communities and countries are prone to emergencies from multiple hazards, and taking a risk-based approach, because not every hazard represents the same threat to a community or country. And doing a risk-based approach allows us to prioritize according to levels of risk and allocate resources. So if we could just quickly whip through some of those slides, maybe to the third or okay. So okay, so I've already addressed remarks related to these slides. And in fact, what I can say is our emergency department in the Eastern Mediterranean region, we have structured our department around the emergency management cycle. We have a team dedicated to prevention and mitigation, primarily related to high-threat infectious hazards, the emerging and epidemic-prone diseases. We have a team dedicated to preparedness, particularly advancing IHR core capacities, but indeed all-hazard preparedness. We have a team dedicated to detection, public health intelligence, and health information management, and we have a team dedicated to response. And for some reason, the slides aren't advancing. So it's important, as I mentioned, to do risks.
Yeah, now it's moving.
Okay, so I've addressed these remarks.
Are we pointing at the right place?
I don't know whether I'm supposed to be. There we go. So, why do assessments and categorize risks for all hazards, not just infectious hazards? Well, I think I've already answered that question. Every country, every community prone to risks from multiple hazards. And doing these multi-hazard or all-hazard risk assessments gives us the evidence to do better planning, to prioritize our resources and activities based on risk, to contextualize. Again, doing a risk ranking helps us to contextualize, at national level and sub-national level, because the risks may vary. And it's also important because doing these all-hazard risk assessments aligns with the IHR. Now, under the IHR, His Excellency the Minister mentioned earlier today that Pakistan's just recently updated the joint external evaluation and is working on the National Action Plan for Health Security. the all-hazard risk assessment and multi-hazard response plans very much complement the JEE and the National Action Plan for Health Security processes. And just to quickly whip you through, this is a methodology that we've developed called the STAR methodology. It has 5 or 6 main steps. Firstly, identifying potential hazards, looking at their health consequences, the scale of risk that each of these hazards may represent, and the exposure that different populations may have to them. Then there's a process of evaluating the likelihood. What are the chances that this hazard may represent a threat to the population? And with what frequency, with what location, mapping, and so on. And then there's a process of estimating impact. What's the likelihood? What are the health consequences? Therefore, what's the severity? What's the vulnerability of the population? Are there specific subpopulations that have greater vulnerabilities? And what are the coping capacities in place? How's it resilient? How strong is the health system? How informed are communities? So it's, this is all part of the assessment. And then from that, taking that evidence and assigning scores to severity, to coping capacities, to vulnerability, we can come up with a risk level and risk ranking, which we then put into a matrix to determine which are the highest risks for a given country or community. And then that information then is translated into helping with mitigation measures, with contingency plans, with all hazard or multi-hazard action plans. And this is the toolkit that we use. A lot of qualitative information used, and then we take that qualitative information, we convert it into sort of a ranking process, and these are some of the products that we. There we go. Oops, now I've gone too far. So some of the products that we can, that we produce out of this process is a country risk profile. What's the full suite of risks and what is their risk level? We then put it into a risk matrix, a 5x5 risk matrix according to likelihood and impact. And that can then allow us to do a risk ranking for a given country or community. We also develop a risk calendar. How many of these risks are seasonal? Which of them might be random? Which of them might be rare but potentially very high consequence? And then these products then establish the foundation for our planning exercises. And there are different types of plans that can come out of this process. With that risk matrix, we can then come up with hazard-specific or emergency-specific contingency plans. We can come up with multi-hazard response plans across more than one hazard, as we've done in a number of countries. This process should also inform our national action plans for health security and indeed, more broadly, national health policies and plans, because emergency preparedness has to be part of our national health policies and plans. And I am sorry that the slides aren't working for us. Anyway, this gives you a sense. This slide really refers to what I was mentioning there, the different types of dovetailing and integrated planning processes and plans that we can develop. Of course, it's one thing to have a plan, it's another thing to operationalize it. And so we take these plans and also getting community buy-in. So risk communication and community engagement is absolutely vital. It's important that I failed to mention that these multi-hazard risk assessments should be done on a interagency or intersectoral basis, and also very much with community engagement. And then the results of those processes and the planning must be communicated to communities. There must be a sense of community ownership and engagement. Again, one thing to do that process and have the assessment, have the plan, but then that's got to translate into concrete action. And once we've done this process, we can advance our operational readiness. Make sure that we are ready to go for the high-risk hazards. And in that process, I often think it's useful to think of the 3 S's. What are the things you must have in place so you're ready to go when the next emergency strikes? You need staff. You need well-trained technical staff. You need emergency managers. You need interdisciplinary teams that are ready to deploy and have the capacity and the equipment to deploy. You need staff. You need emergency funds. You need a mechanism to mobilize funds immediately in response to an emergency. You need stockpiles of supplies and equipment, and you need mechanisms to move those supplies and equipment to the side of the emergency. You need systems. You need early warning systems, surveillance systems. You need coordination mechanisms. You need logistics systems. And you need processes to test and validate and improve your plans. And then you need business continuity plans and another process. So how are we doing rolling out this approach? Well, we've done these multi-hazard risk assessments or all-hazard risk assessments now in 16 countries across the Eastern Mediterranean. We haven't done one here using our new methodology, but we did one around 2018, 2019. As we said, we've recently done the joint external evaluation here in Pakistan, but I think it could benefit from complementing it with an all-hazard risk assessment, given the multiple hazards that this country faces. We've also started now to use this approach at subnational level and also in advance of major events, such as COP27, the Hajj, and so on. What are some of the challenges? Big challenges rolling the approach out in some of our fragile states, particularly those where there is divided government or divided territories, getting buy-in from different de facto authorities. And of course, in a lot of our fragile states, such as Sudan and Palestine right now, for example, very dynamic processes. Getting finalization of the process and the plans sometimes presents challenges because sometimes governments are more focused on the response than the preparedness. In practice, how well have we done to get funding for the results of these plans? I have to say it's a very mixed experience. We haven't been able to use these plans or the results of these analyses to mobilize a lot of funds. And I can give you a very good example, which would be Sudan, which is prone to recurrent cholera outbreaks. It's been very hard to get donors interested in funding preparedness for cholera, as one example. And then, of course, these processes...
Rick, sorry, we'll have to wind up, please.
Yes. Perhaps the final challenge, these processes are not foolproof. We all know about emergencies happening that we didn't predict. Mpox is one example. The recent earthquake in Syria and the dam collapse in Libya would be other examples. So, thank you. I hope that gives you an overview of our approach to emergency management more broadly and multi-hazard, all-hazard risk assessment specifically. Thanks very much for the opportunity.
Thank you, Rick, and thank you for stressing the need for grading of the vulnerabilities, especially it's so critical for the calibrated response. So again, I'm sort of skipping in for a while, so I am going to request Dr. Elizabeth to talk about the role of the resilient health system in readiness capacity. And as we requested, and apologies for squeezing you a bit on because of the time hazard, but please try to stick to within your limit of 10 minutes. So over to you, Lisa.
Thank you. Can I have I am honored to be here today to speak on behalf of the U.S. government, the U.S. Centers for Disease Control and Prevention, and the U.S. Health and Human Services. I do have slides. Are they?
Yeah, can we have slides of Lisa presentation, please? Yeah.
That one's not me.
Yeah,
That's the afternoon talk.
yeah. Slides for presentation number 3, please.
Well,
Sorry, can we display slides, please?
CDC defines health security as the ability to prevent, detect, and effectively respond to infectious disease outbreaks and other public health threats. Developing health security capacity globally helps stop outbreaks from occurring, stop outbreaks from becoming epidemics, and helps reduce the threat of pandemics. Our world is much more interconnected than we have ever been. This is overall a very positive thing, as an interconnected world allows us to visit, to learn from each other, but unfortunately, an interconnected world also allows diseases to spread more easily and rapidly. Unfortunately, most countries do not report compliance with the international health regulations, and an estimated 2 out of every 3 countries is not prepared for a major outbreak. COVID-19 is all too familiar with everyone in this room. The cost of the recent and ongoing pandemic has been estimated to close to 20 trillion US dollars. While most countries are recovering from the most acute effects of the pandemic, we still feel the profound effects on the quality of life. Global health security is important to everyone because a disease threat anywhere is a disease threat everywhere. Given that diseases can arise anywhere, we must build capacity across countries at the national and local levels to stop outbreaks at the source if we, the entire world, are to be safe from infectious disease. Gaps in health security capacity can undermine functioning of health systems, as we saw an extreme during the COVID-19 pandemic. Many non-essential health services around the globe were suspended, reducing the overall quality of life. Here in Pakistan, in Karachi, 18% of child immunization facilities closed during the lockdown, which delayed life-saving vaccinations of vulnerable children. The US government supports the World Health Organization's joint external evaluation. Pakistan was the first country in EMRO to volunteer for the JEE in 2016, and last year conducted a second round of JEE to track progress to international health regulation goals. The JEE categorizes health security capacity into 19 technical areas, which help countries prevent, detect, and respond to infectious disease threats and other hazards. CDC gives special focus to 4 of these technical areas to build strong health security and public health systems. The surveillance systems to detect outbreaks quickly, laboratory networks to identify and confirm pathogens and identify novel pathogens, workforce development to train the health professionals needed to operate surveillance systems, labs, response and epidemiology teams, and public health managers. And then our 4th is the emergency management systems to coordinate effective responses across government and with multiple sectors. We do this in 3 ways, through our programs, our technical experts, and our contributions to global guidances and efforts. We implement programs with partner countries individually or regionally that build the foundational capacities they need to prepare for the next emerging global threat. CDC also helps build capacity in cross-cutting areas that improve their ability to prevent, detect, and respond quickly, irrespective of pathogen. In addition to building these functional capacities, CDC has programs that prepare countries to tackle the high-threat pathogens that we know are out there, including CCHF, polio, and others. CDC also helps through our people. We have world-class technical experts in Atlanta and stationed in more than 60 countries around the world. These staff provide direct technical assistance to partner country government staff to build capacity. And finally, our products extend our technical expertise and our experience implementing programs on the ground beyond the countries we work in to empower global efforts to build capacity and manage infectious disease outbreaks. Examples of technical products, great. Okay. Examples of technical products include the joint external evaluation, as well as contributing to the international health regulations. The COVID-19 pandemic gave the world the opportunity to see global health security programs in action for both good and bad. We identified a number of overarching issues that contributed to a failure to mitigate COVID-19 outbreaks and control spread, including overarching issues in a lack of governance and coordination, equity and access, the resiliency of the workforce and supply chain, and financing. The capability of the worldwide public health workforce did not match the capacity, with gaps in legal preparedness, infection prevention and control, our ability to counter mis and disinformation, difficulties surging the workforce, and border health coordination between neighbors. Numerous challenges have cited legal barriers as one of the major challenges during the COVID-19 pandemic at the WHO's 2021 IHR Monitoring and Evaluation Framework consultation. Legal preparedness is critical and has been neglected from a preparedness perspective. There is a need to address legal challenges to the extent possible between emergencies and not during them, especially given that every minute during a health emergency can mean lives lost. Addressing legal challenges and legal preparedness allows for countries to save time in responding to health emergencies, and therefore, more time and energy are reserved for public health, communication, and scientific dimensions of the response. The Legal Preparedness Action Package is the newest GHSA action package. It was created in September 2021 in response to this identified need. As of August 2023, there are 32 members, including 10 countries, 10 multinational organizations, and 11 in civil society. The action package is developing critical technical guidance tools, including on legal mapping and liability risk management, to promote equitable access to medical countermeasures, especially considering the key challenges experienced during the pandemic. It defines legal preparedness in the context of health emergencies where there was no definition before, and refers to the capability to map, develop, refine, and use legal instruments that enable the implementation of public health capacities to prevent, detect, and respond to infectious disease threats. We thank Pakistan for proposing and encouraging the promotion and use of the upcoming legal framework guide on legal preparedness within GHA. Pakistan has been a major advocate in utilizing the GHSA network to get more countries to commit to conduct legal mapping and sharing the tools and resources available through the Legal Preparedness Action Package. The Sustainable Financing for Preparedness Action Package Working Group was launched in 2019 to take strategic actions for mobilizing global, regional, and country-level resources to achieve sustainable financing for preparedness. The action package does this by engaging relevant stakeholders to take coordinated action, contributing to existing efforts and tools, and galvanizing high-level support. The strategic objectives of this action package are to increase awareness and the support for sustainable preparedness financing, support coordinated action to international initiatives, instruments, and frameworks, and share and contribute to the development of resources and tools. We invite Pakistan to join the Sustainable Financing for Preparedness Action Package to further their work in this important area of expertise. Finally, addressing challenges in global health security cannot be done by any one organization, sector, or ministry. It takes a multi-sectoral approach. This is true in the US as well as our partners around the world. We thank Pakistan for your support as the 2023 GHSA Chair, and we look forward to continue working together toward a healthier, more secure world and preventing the next pandemic. Thank you.
Thank you. Thank you, Isa. We all acknowledge the contributions that CDC is making for global health, and I think the resilient system, they are really key to be ready for the next pandemic. Thank you so very much. So again, I'll continue to breach the order of the agenda. So maybe I can surprise my colleague Abdullah Fadil to be the next. So Abdullah, if you can please talk about the lessons learned from COVID-19 to actually link everything that we are discussing with a real life situation. So over to you, Abdullah, please.
Thank you very much. Good afternoon. I thought I was going to be the last, and I had an hour to prepare. But I think this topic is apt, and this morning you would have noticed I was wearing my mask. I could not speak about COVID, another listed example at the beginning of the session. Let me first start and congratulate the Minister, the Secretary, and the entire team of the Ministry of Health for calling this important summit. It highlights the importance of the agenda, no, I don't need, and how interconnected the world is. And you've heard everyone talk about this morning. We have commissioned a report to look at the COVID response of Pakistan and the actions of government of Pakistan. This report basically comes up with almost 87 actions and 57 recommendations. And they go along the lines of legislation and policy that was in place, the management and coordination of the COVID response, the surveillance, the case management, and all of these points you see. So this report, which I will be presenting to the Minister later today, highlights these 12 elements. I think you can take the PowerPoint down, those colleagues. It's not needed. I just wanted to show the areas covered in this report, and I will just briefly speak about these. So the colleagues who have PowerPoint, you can just take this down, please. So Pakistan, in responding, I said, please take it down. We don't need this. We've experienced enough hiccups with PowerPoint, so we'll skip it. I think Pakistan at the beginning did not have any legislations or policy related to this because outside of the norm IHR. I think government executive orders and directives helped at the beginning. Smart and micro lockdowns also were key to Pakistan's achievements at that beginning stage. Pakistan's management and coordination structures, particularly the National Command and Operations Center, was really critical. The all-hands-on-deck approach, where military, civilians, provinces, districts came together, was crucial. This demonstrated that if Pakistan comes together, actually it can achieve miracles. It was no surprise that the Economist termed, in terms of normalcy index, Pakistan was actually number 2 or 3, only following New Zealand and Hong Kong in terms of coming back to normality more than any other country. So this was a demonstration of a national system approach, an all-hands-on-deck approach that really worked. Again, surveillance system was not ready, but again, the capacity of the polio program to come in and actually support was critical at that early stages, where you have actually almost 265,000 polio workers and almost 100,000 lady health workers coming to the fore and supporting the process, including the test, track, and quarantine program that Pakistan put in place. Initially, the case management was difficult because PPEs were not available, even though sites were created, but the sites management was also not possible. Of course, Pakistan has a number of infection and prevention control strategies, and I think the establishment of physical distancing, the community engagement part, the washing of hands, and all of that also came into place, as well as designated some ICUs and wards at the beginning, as well as training frontline workers. Points of entry, Pakistan had 19 operational points of entry. Again, initially it was not difficult to control all those areas, and I think the management of that really provided some key challenges to the system. The risk communication, I think you've heard from my colleague from WHO, was an area where actually we had used systems in existence already to counter negative, false information. The systems in place, again, in polio played a critical role. The religious leaders played a critical role, and that was actually a key component, as well as some of the strategies that we came up with, including in local languages. Again, vaccines, Pakistan, again, initially deployed almost 350 million doses, covering almost 140 million people, 80% herd immunity. Again, it was a significant achievement that was reached. And again, through COVAX system, UNICEF was able to support the government with almost 120 million doses of vaccine. And as part of the recommendations, we are implementing some of those strategies that came up, including solarization, cold chain establishment, as well as the ultra cold chains that were established at the beginning phases. Again, training of workforce was a critical issue. The laboratory component and getting national systems in place, as well as the PCR lab test, was a key issue. Private labs were supported through subsidized testing kits, and actually Pakistan moved from very low testing capacity to almost 70,000 at the later stages a day. Similar to the rest of the world, Pakistan, of course, faced financial crisis emanating from this, but the response of the government and all hands on deck approach, including the poverty alleviation programs in place at the time, including the Benazir Income Support Program, the GHSA program, really made life easy for the most deprived communities. Again, essential health services, continuing essential services was a key component. What is now, despite all of that great achievements, what is still lacking is a consistency approach in the implementation of those recommendations. Despite this, we still have these 57 recommendations that require close attention. We saw during the floods, some of those capacities actually came into play and actually supported the systems in place. Pakistan is able to respond in terms of crisis. But consistency approach when there are no crises is going to be the key in the next stage. And I think this summit is part and parcel of that approach where we are always ready. So what I would suggest is that our preparedness and our ability to respond really needs to be built consistently and continuously from the district level to the provincial level to the national level. And I think those recommendations, 57 recommendations in this report, are going to be crucial to make sure that the next pandemic, as well as the next climate-induced crisis we face, we are ready for. Thank you very much.
Thank you. Thank you, Abdullah, for reminding those tough but simultaneously the good times in respect that we were able to convert those challenges into opportunities. So I think just as I recall, there were three probably critical things which led to the success that Pakistan could make in terms of COVID response. Firstly, I think the earliest action was critically important in terms of assessing the overall capacity of the system and trying to identify those gaps which were sort of required to be filled on urgency basis, and government and partners then made those resources available as well. I think the second thing that I would like to also touch upon is this effective and efficient use of the pre-existing systems. As Abdullah mentioned, polio, our EPI immunization system, 1166 health helpline, again besides the coordination that NCOC put in place, our public health laboratory at NIH did a tremendous job in terms of unprecedented enhancement of the testing capacity of the country across the board. And more importantly, I think the clarity that the entire management team had at that point in time about the importance of maintaining trust with not only among institutions but also trust with public. Approach the public with truth, with facts. I think these were like three critical factors. But thank you, Abdullah, once again. Now I'll try to restore the order. So maybe I can request Dr. Anne Wilson to talk about the significance of robust surveillance system and public health laboratories network, and also if you can touch briefly upon the significance of workforce development, but you still have 10 minutes. Thank you. Thank you so much.
Thank you very much. Assalamu alaikum. Health Minister, Honourable Health Minister, Secretary, delegates, guests, and I would like to say friends. I'm very honoured, actually, and privileged, and thank you very much for inviting me to speak, and I bring greetings from the UK Health Security Agency. I see there are some slides, so let's take a chance here, and I'll try and go through them as quickly as I can. I'm going to quickly run through, and I'm going to say a little bit about myself and the experience I have, and the reason I do that is because I want to establish the credentials. I'm not sitting here as an expert in the sense of academia or literature. I'm sitting here, as Dr. Safdar has said, as someone who's been working in public health practice for, dare I admit, 30 years, and that I have experienced outbreaks, epidemics, pandemics. Then I'm going to talk about what I was asked to talk about, some of the essential attributes for response and pandemic preparedness, and you'll already have heard some of that. Then I'm going to say about a little bit of the learning, and then I'm going to leave us with a challenge for the rest of the day and into tomorrow. So first of all, medically qualified, worked clinically for 10 years in Africa and in the UK, and I then specialised in public health protection, so a communicable disease consultant, working, as I say, not only in infectious disease response, but also, and it's already been mentioned by my colleague from MRO, about all hazards. So I was responding to chemical incidents as well. But it was 2016 when I was given the privilege of the invitation, and I see friends in the audience, to come and work in Pakistan with the Ministry of Health, the National Institute, and the provincial governments, specifically on integrated disease surveillance and response, and this was one of our workshops back in 2017. I now head up the whole project for the GHSA, funded by the Department of Health, and we work not only in Pakistan, but Southeast Asia. There's a small team. We work with Africa CDC, with Ethiopia Public Health Institute, and with Nigeria and Zambia, and you can see some of the epidemics that we've been supporting them in responding to. So there's a range of experience that I bring to these comments from across those areas. So it's about strengthening systems, building capacity, and strengthening leadership. So we've also been part of the COVID response, not only in the UK, but here in the countries where our teams were. And of course, we cannot forget the pandemic in 2009 and the Ebola outbreak. All major significant events that we, public health doctors and practitioners, and many in the room have responded to. So in terms of what are the essential attributes, I would do no better than to point you in the direction of this report, set up an independent panel, set up by WHO, and reporting into the Lancet in 2012, where they were recommending transformational change in what we do. So basically, we're talking about, and it's already been said, surveillance in terms of an early warning system. It's really, really important to identify that we have a problem early. Then we have to be able to confirm that we have that problem through laboratory systems. But the other point, two points that I've pulled out here are about these partnerships at multiple levels across government and outside government, and also the engagement of the community. So I don't know about you, but that's not the only initiative and report post-COVID. There are so many initiatives that now come out in the last few years, and don't get me wrong, they're all really, really important, and they're all really, really good initiatives. But I don't know about you, but certainly where I sit, I tend to get a little bit overwhelmed because I'm not quite sure where to start, which to prioritize, and often it's the same few people in each of the countries, all countries, who are dealing with these. So what I want to look at in terms of essential attributes is look at it slightly differently, and I want to ask us all to think of the systems that you work in at the moment. We think of the mechanisms we have, and that we asked ourselves 3 basic questions. Some people in the room will smile because you know I like 3 pillars. But these are 3 questions. If you look at the centre, first of all, in terms of the core, and what are our early warning systems like? Are they robust enough? Will they do what we need them to do? Then, as already been said, in terms of workforce and capacity, can our systems cope? And finally, this point about coordination and collaboration, and that's where I will finish, and I think it's very important. Let me take some examples and some learning. In terms of early warning systems, I really have to congratulate Pakistan. I came here in 2016, as I said, specifically asked to support integrated disease surveillance and response. And you have really progressed. Unbelievable the work that has been done, where the system that has been set up is now in over 90% of your districts. Data is flowing to the centre and back out again. There's a lot of work still to do. The data is flowing, but there's a lot more needs to be done on the analysis and what it is telling us and how it gets embedded. And we have been fortunate to support, as has WHO and other partners, in helping you design and roll out this system. And of course, in the flooding, you were able to use it in the flooding. In terms of labs, I'll take you to Zambia. I went there 3 weeks ago to see our team in Zambia. And this is in the Copper Belt. And for the first time in Zambia, at a sub-national level, the public health laboratories have come together. They are talking to each other, they are supporting each other, and they are learning and sharing together. And I know there's been a lot of lab work here, but I just thought I would take you to another country. So in terms of rapid response teams or rapid support, this is from Ethiopia, and basically we have been doing some training in relation to that. In terms of capacity, what I want to say is it's not just the specific capacity training in terms of the specialist areas like laboratory diagnostics, or the bottom picture is environmental epidemiology. We need to support, and with these documents with WHO, and then in testing with WHO, we have been doing a lot of work about competency-based training. So not one-off training and then leaving people on their own, but competency-based training that then there is supervision ongoing. And that is very difficult for all of us because of the turnover of staff. So finally, I wanted to talk about coordination, and it's been mentioned quite a few times already in the summit. Do our mechanisms that we have in place adequately communicate effectively so we can collaborate and coordinate together? The strategic plan that's Africa CDC here that has just recently been released, that we were involved in terms of public health emergency operations centres, and then of course the WHO multi-sector coordination collaboration, really important documents. So have we really embedded those, or are they nice documents sitting on a shelf? Our learning from each of these areas has been that we will never have the early warning systems we really want. We will never have the capacity we all want and need, and we can say that across many countries. But my experience over the years has been that if you have coordination and multi-sector relationships as a priority, you can address whatever comes down the road better than you would if you were not collaborating, coordinating together. So the main thing I've learned in my 30 years of public health practice is that the most commonly forgotten essential attribute of preparedness and response is actually collaboration. We talk about it, we say nice things about it, but do we actually do it the way we need to do it? And also, the most commonly forgotten essential attribute of collaboration is good quality relationships. And I am very thankful in the years that we have been here that we've established good, trusted relationships with many people in the room, and we can have very detailed conversations because, as one of our ministers said in this statement to the UN, that the pandemic, there were many high points of cooperation, but actually many and too many low points of isolationism, and we need to make sure that doesn't happen going forward. Our project is all about building relationships of trust. And we took our time and we asked the questions of what support was needed, and we believe very strongly this is the key, and someone else in the panel has already mentioned it, in relationships of trusted quality, where you can challenge each other as critical friends and therefore collaborate and go forward together. So finally, I would like to add that it's in the literature as well, a lot has been written. We need to see collaboration as an evolving process. It needs to happen at all levels, it cannot be one-sided, and that we need to participate in joint activities, not just talk about it and have a shared goal. So yes, relationship is important, but it's a process. It's not that we have a collaboration. It's not that we are a collaboration, but it's that we engage in collaboration in an ongoing manner. So these initiatives, we really do need to push forward on them. And hopefully I'm sort of stimulating some ideas, and I really want to have more conversations in terms of what do we mean by collaboration today and into tomorrow and beyond. Because I suggest that this summit, and I really congratulate you on pulling this together, Minister, great leadership, and thank you for it, and an opportunity for networking. But I suggest it's a great opportunity that we learn together. We all have to learn from each other. We continue to build the relationships of trust, and that we take a deeper approach to collaboration, so that in that way, together we can achieve stronger, more effective global health security to be better prepared for the next pandemic or emergency that will definitely be coming. Thank you.
Thank you. Thank you so much, Jane. I think, again, many states across the globe, they have started doing a very good job in terms of collection of information. I think one area where we all need to work together is now linking this information gathering with response. That's probably the component which is missing. And as one of my friend used to say, that surveillance without response is actually merely counting of human miseries, and we should be avoiding that situation. Thank you, Anne. So now it's time for our friend Supriya. Now we are going to actually talk about the significance of resilient health systems, and we will listen from Supriya in terms of the ways for monitoring the essential health services and health systems during health emergencies. So over to you, Supriya.
Thank you, Dr. Rana. I also have slides, if my slides can be brought up. Thank you. So good afternoon, everyone. Thank you once again to the organizers for extending an invitation to the Global Financing Facility. Also want to congratulate the government of Pakistan on this important milestone. So what I'd like to talk about today is the important aspect of resilience, which is to make sure that we protect essential health service delivery during emergencies, and do so through some robust monitoring. So very briefly, how can essential health services, which primarily impact women and children, how can they be affected during an emergency? Well, we would see supply side impacts as well as demand side impacts. So on the supply side, we can see disruptions in supply chains. We can see reduced availability of services. And during COVID, we certainly saw huge strains on human resources. On the demand side, we had many contexts during COVID where people were really just scared to use health facilities. We had some pretty severe lockdowns in place that limited mobility. And certainly people had a reduced ability to pay for services. So given that we knew these disruptions were possible, I think the GFF decided during COVID, given how crowded the response space was, that our biggest value add could be to support countries to monitor essential services, specifically through looking at demand and supply side shifts. So very quickly, we focused on deploying and refining a set of 4 complementary tools to monitor essential health services. So one was the use of countries' own administrative data from the GHSA. The second was to do rapid cycle phone surveys to health facilities to get real-time data from the front line. The third was using an existing tool we've had for several years. It's to use our resource mapping and expenditure tracking tool to look at shifts in budgets and spending. And finally, we also looked at doing household phone surveys to look at health-seeking behavior. So very quickly, the first tool was DHIS2. Almost all of our partner countries, and certainly almost every country in the world, is now operating on DHIS2 to house their HMIS data. And we realized that if we could look at historical service delivery trends, looking at a few key services like ANC, family planning, immunization, we could look at past trends and be able to model future utilization, expected utilization, and then look at actually what was reported in the DHIS2 to look at the gaps and look at the shortfalls and disruptions in services. So in this way, this graph might be a bit hard to read, but we can see this is a graph of OPD consultations and looking at volumes of OPD. And we can see that across countries, countries had a very different experience of disruptions in essential services. So on the left, the very left is Bangladesh. They had quite a severe drop-off initially, and then they managed to recover. Versus a country like Nigeria, which experienced a protracted deficit in service utilization throughout COVID. But we also know that DHIS2 systems that had really high quality subnational data enabled us to help countries do equity analyses, because I think we always risk looking at aggregate data at the national level and really miss hotspots that might be happening in very localized areas. So this is an example of immunization, quite sensitive. We were able to detect declines of even 5% across a range of antigens and across a number of countries, time points, and subnational locales. So very useful for health systems planners. The second tool that I mentioned was that we were able to deploy on a monthly basis rapid cycle phone surveys to health facilities. So we would do this with a random sample of facilities every month. We would query the facility manager on a range of resilience indicators and actually hear from them what kinds of shortfalls they're having and be able to triangulate that with the data we were getting from the DHIS2. So, for example, this is kind of hard to see, but if you take one important measure of resilience, infection prevention and control, you'll see across many of these countries rather severe deficits in this important indicator. And based on this, health ministries were able to send out, for example, additional PPE to the field based on what was reported on phone surveys. So very real-time data, very low cost. Each round of these could be done for under $50,000. The third tool I mentioned was resource mapping and expenditure tracking, which we've now been working with our partner countries for several years to do, including Pakistan. And here we were actually able to see, for example, in Chad, DRC, and Niger, we noted that resources that were supposed to go to essential health services were actually being reprogrammed away and towards to finance the COVID-19 response effort. We could also see where there would be shortfalls in necessary inputs for vaccine rollout, for example. So another very important data point in the arsenal. And finally, the fourth tool was household surveys done by phone, again, to actually look at user health-seeking behavior. And really, this was important because it told us what non-users were thinking and their reasons for non-use of the health system. So, for example, we did this across 16 countries, and we found, to no surprise, that the single biggest reason for non-use during the pandemic was financial barriers. So basically, we were able to deploy these 4 tools, refine them during COVID. We have some lessons, basically, on the HMIS front. This is data that countries already have. So very, very low cost, and it really pushed the data quality and data use agenda for decision making. And many countries have come back to us now asking for help to institutionalize this support. On the rapid cycle surveys, again, very cost effective, can give very timely information that you wouldn't get with an in-person survey. And again, some aspects of this can be institutionalized to build resilience in health systems. So at this time, we have this suite of 4 tools, and our program going forward is to help build capacity for countries who have requested TA from us, to institutionalize some or all of these tools, and to really help on the data use front. So why is this important? Because one, we have a real focus on improving data quality, which in and of itself is a hallmark of resilience. We have the ability to keep monitoring service volumes. Even small changes in service volumes can flag a problem. And finally, we have a great way to monitor coverage of essential services, and we can get ongoing coverage estimates. So in this way, we think bringing a real implementation science lens to this, we think we can help countries build resilience in their ability to collect, analyze, go back and have responsive programming and refine their data and improve their data collection. So I will stop there. Thank you once again.
Thank you. Thank you so much, Supriya, for sharing your nice experience. Actually, again, what we have observed during emergencies, everybody is heavily focused on in terms of reducing the morbidity and mortality associated with the immediate issue. And many times we tend to forget the importance of the essential health services. So I think keeping a close track really saves a lots of lives as well. And again, just to share our own experience with the audience, when we had this COVID-related interruption in healthcare service delivery, our immunization services, they were badly affected, both fixed site as well as outreach. We also had to sort of shut down our door-to-door campaigns. But we conducted an immediate risk assessment, and we were able to quantify the potential implication of that halt. And when we presented in a dedicated session at NGOs, our entire political leadership, administrative leadership, military leadership across the board unanimously said that we can't afford it. Please restart immediately. So I think that's the significance of doing a real-time monitoring, and definitely we have some good lessons learned as well. So thank you, Supriya. Now we are going to actually touch another very, very important area, which is family planning, yet another important component of essential health services, which is often ignored. And we are fortunate to have 2 speakers over here. So firstly, I am going to request Professor Mahmood, and then afterwards, my colleague Dr. Rehana will take over. So Professor Mahmood, over to you, please.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and good afternoon. I think it's very privileged to be over here, and thank you for inviting. This morning, I was very touched with the respected Federal Minister of Health. He said a wonderful thing. He said this conference is going to be a catalyst. And I immediately thought, I do not need to talk about the family planning, other things. Let's talk about the experience that how could we make this summit a catalyst to make a difference across the globe. So I am a ministerial advisor at the Ministry of Public Health, and it's again a privilege. But I served with the responsibility to provide professional leadership to Public Health Scotland at the midst of the COVID before I moved to Qatar. So I just felt, being the medical director, seen a lot of outbreaks over the years, starting with SARS, then Zika, and so what are the things which are going to help us to achieve the outcome? And I put the outcome on the top. Enhancing policy and impact management, because if we can achieve this out of this summit, then it is going to be a great outcome. The first question I asked myself all the time, that when we think about effective pandemic preparation, what are our goals? Let's keep it simple. Every country defined public health system in different way. If we can define the public health system, and I know in the back home in the UK and now in Qatar, which is again one of the success story of dealing with the pandemic in a very effective manner, we define these. So one of the preparation is that you need to be ready when the slides don't work. It's working, okay. I can't see it from this end.
This screen has gone off. If somebody can help, please.
It's fine. I think it's back. As long as it's working, it's fine. I don't want to waste time. So the countries who were successful, they said very clearly, public, private, and voluntary sector. And when they said our public health system is consisted of all those three, then they had the bigger capacity and capability. And the second thing was that they were very, very clear about the goals. I think we use these words, the timely, comprehensive, and I think the equitable response. Because if you look at the countries who've been very successful, they tick all those three boxes. Then the goal was saving lives and also improving the quality of life. Efficient use of resources. But I think the last, the colleague speaker said very, very well, that collateral damage. Because you can see in the UK there is a long waiting list. And the number of countries, they are saying, if every life is equal and precious, if someone is dying of a communicable disease or dying of a non-communicable disease, outcome is the same. So while we are thinking about the communicable diseases and emergencies, we need to be thinking about the non-communicable disease at the same time, because that is what people felt, that that damage which happened after COVID. Let me very quickly say that if we go back almost 125 years, and this is the data which was published in the New England Journal, most of the mortality in 1900 was coming from infectious diseases. Fast forward 110 years, it is non-communicable diseases. Then what happened next in the last 15 years? We had SARS, we had Zika, we had the Ebola, and then we had COVID. So what it said to us, to all of us who are in the health system, that our public health system is weak. So there's a difference between the health and the health care, because the health is physical, mental, and social well-being. The countries have developed a very strong healthcare systems, but their public health systems are very weak. On the similar note, thinking about Pakistan, 2005, they had the biggest earthquake. 2010, they had the floods. Then subsequently, a lot of other challenges. I think they have learned with experience, and a lot of other speakers who worked very closely with Pakistan, they said that they have definitely punched above their weight. But at the end, thinking about the public health system is weak. And then the public health system, again, I do not want to go and try to define it, but at the end of the day, this is the WHO who defined it very clearly that there are 8 or 9 elements. But I think what I felt over the years that there are few elements which are more important than the others. And I felt that if we want to deal with the future pandemic and we want to think that how effectively we can prepare, then we need to shift the paradigm. The paradigm needs to shift on the few fronts. First one is from data to applied intelligence. The countries collect a lot of data and sometimes they are data rich and intelligence poor. And I think we need to shift the paradigm that we need to collect the data and then develop the applied intelligence which can be used in order to prepare and both for communicable and non-communicable diseases. Other thing which over the years has happened, moving from medical to multidisciplinary public health workforce. Because this is another challenge, because maybe there are a lot of medical schools, they are producing a lot of doctors, but at the end of the day, if you want to strengthen our public health system, and again, the UK actually led it by example. In 2002, they have opened up all the public health positions equally for the doctors and the non-medicals. So basically, they raised the standard and saying that yes, we need to have a multidisciplinary public health workforce, which can be, I mean, I don't know, maybe it's about 130 medical schools in Pakistan, and I don't know how many of them are producing the multidisciplinary public health workforce. Third thing, slow versus fast emergencies. I think most of the time, the whole world get together, including WHO, thinking that yes, when there is an epidemic, we need to, and pandemic, we need to prepare. But slow emergencies are as important as the fast emergencies. I mean, it was said AMR, antimicrobial resistance, it is a slow emergency. But the similar note, that all the non-communicable diseases, they are also slow emergencies. And I think we can learn the lessons from the fast emergencies and translate into the slow emergencies. And then last but not least, the horizontal versus distributed leadership. I think my personal experience, I think we are, in the UK, we are 4 nations, and every country has got public health organizations. So Public Health Scotland, Public Health England, although they have changed the name recently, and then Public Health Wales, and then Northern Ireland. And we felt when the COVID happened, each and every country has got something to offer. Rather than we have a vertical, we had a distributed leadership. And again, that is applicable in the regions, and I think we need to work closely with the countries who are very specialists in that particular domain. Each and every ambassador who spoke this morning from Turkey, from Saudi Arabia, and other countries, they had something they have developed. And it means that they were stretched and then they used the opportunity to develop something. And can we cash on that? And again, very quickly, when we talk about data, most of the countries are very good in the clinical data. Then some countries, they might be good in lifestyle data. And very few countries in the world, they are good in collecting in a consistent manner the social determinants data. And I think in Scotland, they are doing pretty good job. And I'm sure the other 3 nations in the UK as well. But looking back in Scotland, they divided the country into 6,976 data zones. In each zone, there are 760 people live, almost on average. Then they collect the data on the 7 domains, that where they work, how their health is, how the transport is, how many green spaces are. And when the COVID happened, we used that data very, very effectively in the Public Health Scotland to identify high-risk patients and in order to give them the right intervention. And I think by utilizing the integrated One Health data as shown in the screen, and the CHI stand for Community Health Index. So every person who lives in Scotland has got a designated number called Community Health Index. I think the idea came from Scandinavian country, and subsequently in 2016, the England and Wales and other countries, in Northern Ireland, they started using the NHS number. But Scotland is using this number, CHI number, since 1969. So they can do retrospective data linkage and they can do prospective data linkage. And this was going to be very, very helpful. And then again, the Scottish Infection Intelligence Platform, now most of the countries are doing it. But it was developed 10 years back. I think when I became the medical director, there was a wonderful team that done the excellent work. So all the data from all the labs got collected, collated, analyzed, and utilized. Now it is very, very mature. Then I think now coming to Middle East, talking about data, the 3 countries are done excellent things on health information exchanges. Saudi Arabia has got Nafis, UAE has got Malafi, and then Qatar is not, but they have developed their own health information exchange. What does it mean? They are collecting all the health data on each and every individual so that it could be used in a very effective manner in the future. So I think I will conclude by saying that this summit has given us the opportunity that we need to make the difference, but the difference needs to come by creating knowledge and utilizing knowledge. Thank you.
Thank you. Thank you, Professor Mahmood, again highlighting the significance of converting data into intelligence and more importantly, information exchange to fully benefit from this effort. So last but not the least, I'm going to request my friend Dr. Rehana to speak about the significance of family planning services, please. Over to you, Dr. Rehana.
Thank you. Assalamu alaikum and good afternoon. Honorable Minister and all the guests, thank you very much for your patience and putting up with all the IT issues that have come up. If I didn't have the slides, I would make my statement anyway. I am just amazed that we are talking about many things and not mentioning the elephant in the room. So I'm going to talk about 3 things, focus on 3 things. And to highlight my first point, I would like all of you to lift your right hand up and place it on your right eye. Can you see? Remove your hand. Can you see better? Definitely. And I think right here, the public health system kicks in. There's mixed health systems. Next slide. Slide, Didi. Most countries look at the big picture, and the health systems are mixed. There is the public sector, the private, and the private also includes the not-for-profit. And partnerships and contracts have to be utilized. This is the recognition that is required. And it has been recognized again and again that we are working with one eye closed, and that we are not seeing very well. Now, the issue is that we need to rectify that. Until and unless we do that, we will continue to break our promises. We have already broken one big promise, which is the FP 2020. We did not achieve our commitments. Our ministers and health staff went and signed the commitments, and we did not achieve it. And now, just about 6 or 7 years to FP 2030, I promise you we are not going to achieve the goal until and unless we open both our eyes fully. And I think right here it was explained as utilizing the public health system fully. Now, FP 2030 has prepared a global private sector engagement strategy. And it has laid it all down. We know it all. It's a question of the public sector managing the private sector, making contracts and using it. You see, the private sector is vast, and it needs to have a landscape. It's not just the donors and the foundations and the investors. It's the media, it's the pharmaceutical, it is the supply chain, it is the hospitals and the doctors and the pharmacies and the informal sector. Wherever people go to seek knowledge and health is the private sector. Please remember that the private sector is customer friendly. Please remember there are many terrible things about the private sector. They want to make profit, yes, but they are not doing public health. And if they're doing it, they are charging exorbitant fees. So now it does need to be harnessed. Now this is the big picture. And global health security, I also liked what was just said, that to me it sounds like this is a slow emergency. Not the fast one, but this is a slow building up emergency, and we hear figures, and you in your concept note have put down 247 million. The last I read was 225. What's happening? Surely we need to take action on this. My second point is that at the level of implementation in emergencies, there is an international standard. It has been laid out by UNFPA, by FP 2030, and various other international bodies, that the minimum requirement at the start of an emergency or a crisis are 3 things which should be rolled out. One is contraception, and actually when people are displaced, they do not want pregnancies. They do not want to have babies. How is it that this is going to come about? It is an emergency crisis situation. The second is maternal care, and the third is the critical thing, sexually transmitted infections, their prevention and their treatment. This is the core package that is listed. There are toolkits. It is all very well and very clearly laid out what has to be done for SRH in case of an emergency. Are we prepared for that? Well, not really, because we are only seeing with one eye most of the time in most of the countries. My third point, next slide please, is even lower down at the implementation level. And I take the 2 examples that have been coming up again and again because they are the most recent, and that is the COVID and the flood crisis we've had in Pakistan. And this is at the level of our organization. We are an organization that conducts training of health providers, private and public. We are an organization that delivers products and trains for clinical services and develops franchises with the private sector. Now, how do you do training when you can't even face each other in a classroom or in a closed setting? So the idea of online training, as most people went into meetings, we went into training, and a TCI, or the Challenge Initiative University, has been conducting these trainings and continue to do so. I will ask my colleague to say 2 or 3 words in a minute, as he leads as Chief of Party on this particular aspect. The online platforms were very interesting. Services, actually no product, no program. With family planning, you need contraceptives. The product has to be made available at the time of need. And so if people were not stepping out to buy the product, or the government was not distributing it, how were they to get the contraceptives? We came up with the innovative idea of home delivery and used platforms like daraz.com, dawa.com, and so on. So a new channel of delivery opened up. It was an innovation. It was an e-commerce. We made a lot of money, which got plowed back into the non-profit that we are. So we realized, is that too loud? Sorry. So we realized that we had actually opened up a whole new channel, which was very cost effective as well, and that we could deliver products to the doorsteps. The COVID awareness was another area which we integrated into our program. All the various things that have been talked about, hand washing to all the other requirements that were for COVID. And this went through the service providers because we are a franchise. And we had all these providers waiting for the clients to come. We ensured they had the kits and they were ready to serve the clinical requirement for these clients. And during the floods, we partnered with the government to help the flood victims in Sindh and further up country. So innovations is something that comes out in the time of crisis as well, and then it can be incorporated into the program. I also liked what Mr. Abdullah said. He pointed out a flaw for Pakistan and said we are very good in crisis, but it is in the regular programs that we seem to be unable to sustain. So I think all the learnings from the crises have to be incorporated into our systems. And with that, I would like to say my concluding remark, next slide, which is that we need some call to action. This summit has been called as a catalyst. I'm not sure I would call it that. I would say it's a summit asking for call to action. And what are the actions we require in the area of this slow emergency of rapid population, which people just in power refuse to recognize? Clearly, there needs to be continuity of family planning services during emergencies. There needs to be funding and commodity security. No product, no program. Again, you need private sector. You see, the youth in this country is voting with its feet. It is bypassing public sector clinic, going to the private clinic, because that's friendly. That keeps confidentiality. I think we need to recognize that there are efficiencies that can be pulled together. And again, educate the providers. Once they come out of college, really there is no ongoing training. It's their own effort. So that is something for sexual reproductive health requires training and attitude change. And then, of course, the requirement of the universal health coverage. I just met a young man a little while ago, and he said, yes, they're working on universal health coverage, and there's nothing about the private sector in it. I was quite amazed, and I think I would like to bring it to the notice. The minister has gone, but there are others. Please take note of it. We still continue to look with one eye. And we have a huge youth population who are crying for help, and we are not able to supply this. It is a slow emergency, and it should be highlighted in every forum, not just this one. Thank you.
Thank you. Thank you so much, Dr. Rehana. We definitely need to look through our both eyes. I think we are all convinced on that. Again, apologies to the panelists. I have been pushing them hard in terms of time, but still, I think your talks were really thought-provoking. Now we are going to move to the question-answer session, and I think there are some important aspects of what our experts shared that we would like them to dilate upon. So maybe to start from my immediate neighbor, Anne. Now, considering this broadening horizons of surveillance and these new tools becoming available, like environmental surveillance, genetics, genomic surveillance, then we have this use of technologies. AI is playing a critical role. So how do you see the future of surveillance shaping up? And more importantly, what is it that the developing countries need to put into their plans right now so that they are not left behind in future? Please.
Thank you very much. Surveillance definitely has a future, because if we don't have surveillance, we don't know what we're dealing with. But my experience has been, when you talk, even in our own country, about surveillance, and our organisation has been, we're now the UK Health Security Agency, we used to be Public Health England. And a lot of that has come out of the COVID pandemic. But there's a very, very big focus back to data, shiny screens, lots of graphs, get the information, and not, as you said earlier, the link to response. And I find it in all the countries we work in, Because in one sense, that's easier to get your head around, but we don't know. Surveillance will help us know what's coming, but the preparedness we need to respond to whatever comes, they're generic skills. So somebody like myself and some of the other folk in the room and my colleagues, we were on the front line of public health in a small country, albeit, dealing with whatever came through the door. And you had generic skills that you then responded to, whether it was an environmental incident, whether it was an infectious disease, whether it was a health service continuity, or whether it was a mass casualty or a severe weather incident. The surveillance definitely helps, and you need it because you need to know what you're dealing with. But in the beginning, you need to respond. And you need a generic group of skills, and that's where the system, and back to what somebody in the panel was saying about our public health systems, in the non-emergency situations, need to have a cadre of people who are ready to do that first piece. And that's where we hope, with some support from partners, we can move forward in Pakistan and take this great progress with surveillance, but focus back on the use of the data in the non-emergency situation as well.
Thank you. And actually, yes, in our experience, what we have seen, this fantasy of this new technologies, they at times they take you away from your core objective, yes. which is to act immediately, yes. and then reduce the miseries of the people who are really being affected. So thank you
yes,
so much.
Sorry, I want to say that happens with us as well. It's not just low middle income countries who don't have capacity. We have that challenge as well, and we are constantly saying to our bosses, don't worry too much about that sophisticated technology. Let's get the basics in place first.
Sure. Thank you. So Rick Brannan, now over to you. Now you have been working over the years very closely with many countries in respect of their global health security plan, their national action plans as well. But one thing that we are struggling with, there are actually a number of plans in a given country. You have the SNAPs, you have multi-hazard plan, then you have hazard-specific plans. And what majority of the countries end up doing is they come up with beautiful printed plans which go to the shelves. So again, learning from your experience, what's the best way of actually aligning all these plans so that we have a consolidated and a very clear direction of how we are going to take it forward? And just again to benefit from your experience, if you can also briefly touch upon the significance of global and regional collaborations in the same context. So over to you, Rick.
Yes, it's a great question, and one for which we don't have a good, crisp answer, unfortunately. I think you're absolutely right that there's been, emergency preparedness and response plans have been a growth industry, hazard-specific plans, pandemic preparedness plans, national action plans for health security, multi-hazard preparedness plans. And I think, for me, a lot of the stuff about the answer to planning is process, how you actually do the process. So what often happens is these plans are done by different groups. They're done almost in isolation. So the National Action Plan for Health Security is done by a different group than the group that's doing the multi-hazard plan. So I think, look, there's some good guidance and templates about the outline of plans, but I think so process is important, using a similar type of approach, using similar type of analysis. Having all the relevant stakeholders in the room owning a plan is absolutely vital. I saw one country, and I'll be honest, it's a plan that one of our country officers developed, and the wrong people were in the room. I'm sure that plan is going to be sitting on the shelf. So I think that I think process is important in terms of baseline analysis, in terms of having the right stakeholders in the room, in terms of the right type of analysis. and then ensuring that plans dovetail with each other, that there is overlap, and this is important not only at the national level, that the National Action Plan for Health Security speaks to the multi-hazard preparedness plan or a hazard-specific plan, but there's also dovetailing at national and subnational level, that the subnational plans are linked. It also gets back to how you manage emergencies within the country, and I would relate to that at the emergency management arrangements. Who is responsible for what? You know, we have countries in our region now that have an emergency department within the Ministry of Health and have a National Public Health Institute like a national CDC, and they're butting heads. There's not clear clarity on who's responsible for what. So, you know, it has to be a context-specific approach, but there's some sort of general points that I would point to, and I think the regional and global organisations such as WHO, we have a real responsibility in the way that we provide technical and operational support for developing these plans to be very conscious of the principles I've just laid out. Dr. Rana, if I may, I'd just like to spend a minute just about another lesson learned on the pandemic. We've just done a study across the 22 countries of WHO in the Eastern Mediterranean region. And what we noticed, particularly in the low and low middle income countries, is tremendous expansion of capacities with the COVID funds on surveillance sites, on laboratory capacity, on public health emergency operations centres, on oxygen generating capacity, on new technical capacities and technical units within ministries for infection prevention and control, for risk communications and community engagement. What we're seeing now is a lot of these countries saying, we don't have the money or the plan to sustain those gains. And I was in one country recently, prior to the pandemic, a Central Public Health Laboratory was on its knees. Now they've got a vibrant Central Public Health Lab and subnational labs. And I said, well, how are you going to sustain this now? And they said, you're going to pay for it. And it's an important point because we are starting to see the fall off of capacities very rapidly in the low and middle income countries of our region. And I don't think we're talking enough about it. I think governments, ministries of health, executive branch of government, Ministry of Finance have got to find some way to rationalise, we've got to right-size those capacities, institutionalise them, integrate the new lab capacities into the systems, integrate the new surveillance sites into the broader integrated systems, and we've got to put this into our approaches to donors, including the new pandemic fund. But for me, otherwise, if we don't do this, we're really going to get back into the cycle of panic and neglect.
Thank you so much. So, Lisa, again, we all spoke about the significance of the resilient health system. But we do know that but in whatever situation we are working, health always has a limited resources. So it has lot of dependency on other sectors. And we also, I think, COVID experience has clearly told that unless we all leverage our strengths, we cannot get the kind of results that everybody wants to have. So again, we would like to listen from you in that how we can really best benefit from the strengths of other stakeholders, particularly non-health stakeholders. But that's an area which is being talked about since years and years, but perhaps we still are not there where we should have been. Over to you.
Yes, thank you. And as you said, health doesn't have the resources to do everything, and health can't be expected to do everything. No, you can never have a single sector responding to any emergency, even a public health emergency. It always needs to be a multi-sectoral approach. So you need to get everyone into the room before there's an emergency. You need to build those relationships. You need to collaborate, as my fellow panelists have said. build those relationships before an emergency so that when something happens, you know who to call in order to mobilize money. You know how to get the funds to where you need to get them. Communication is incredibly important during an emergency of any sort. And so calling on your Department of Education to help deliver messages, calling on the people that you've identified as the leaders in communication in your country, in your province, in your district, calling on them to help you deliver the messages that are needed. Misinformation, disinformation was a big problem during the COVID pandemic, not only in Pakistan, but around the world. Every country has examples of misinformation and disinformation that was being circulated about COVID. Calling on your Department of Education to help educate people on how to critically evaluate sources so people can grow up learning how to trust, what messages to trust, how to determine if a message is trustworthy or not. And then finally, determining who is best positioned to be able to call on the question at hand. So for example, in the United States, when it came time to distribute COVID vaccines, it wasn't the health sector that was distributing the COVID vaccines, it was the United States military. And that is because the best logistics in the United States government was not the health sector. The best logistics in the United States government was the United States military. And so instead of asking the health sector to create something brand new, asking the health sector to say, you've never done this before, but now we need to make sure that you can get this vaccine to every pharmacy around the country, including one that is 30 miles away from the nearest town. Instead of asking the health sector to do that, we asked the military to do that because the military knew how to do that. We also called on private partnerships with UPS, with FedEx, with these companies that are very accustomed to delivering packages. We said, hey, can you help us deliver vaccines? And they said, of course, we would love to. So knowing who in your government and who in your private sector is the expert at the question at hand, and building those relationships before the emergency happens will allow you to leverage them when you need them. Thank you.
Thank you, Lisa. This is very useful. So Supriya, I think you shared a very actually interesting experience of working with different countries. In terms of the quality of data that HMIS is collecting, again, we have lots of variation. So considering your experience of work with different countries and with different kind of challenges, what is it which is really hampering the use of HMIS data and the information in identifying and addressing the gaps that are really halting us from marching towards our objectives? Very briefly, please, in a minute or so, please.
Thank you, Dr. Rana. Really great question. I think, a bottom line for us is data use begets data quality, and data quality begets data use. And we have seen over time, working with countries, that those who have great political will to improve data systems have in fact improved data quality, timeliness, completeness over time. During this COVID-19 essential services monitoring work, but after that too. I think we have the example of Ethiopia, who very deliberately, after every household survey, has gone back and tried to look at the degree of concordance with their routine data, with their HMIS. And over time, that gap is definitely closing because they have such a commitment to improve data quality and data use. So I do think it comes from the top. Sort of to inculcate this culture of data use. Even when you start with bad data, over time it will improve if people are using it. So, and really we'd like to see use by districts, district health offices, district health management teams. That's really where the rubber hits the road, where especially in emergencies, those are the people who need to see what's happening at the front lines, can reallocate resources accordingly. That's where resilience really comes through, where you have data quality. So So I do think it's a cultural shift that needs to happen, but we really need to see the political will from the top.
Yeah, thank you, Supriya. Actually, it's data utilization at the most peripheral level, which is going to improve the quality. Thank you. So just in the interest of time, Brother Abdullah, are you ready for my exploring question? so just again to benefit from the talk that you delivered and shared this sort of assessment report. Many countries like Pakistan, when this COVID challenged them as states and nations, they put in lots of resources into different aspects of health emergency management. Although again these investments, they were extremely useful, but still they remain sporadic. So I think I would really like to have your thoughts how now we can build on those investments and lead those actually investment towards the building of a stronger system for health management in the countries.
I think this is a very complicated question. Perhaps I will answer it in a philosophical way. Countries that value their people make the right investments in their people. And I think consistently you will see across societies, and when I say value, I mean how the public receives services from garbage collection to healthcare and education. It's the kind of commitments you make to your population and the kind of social contract you have with your people. What are you willing to invest in, right? And I don't think those social contracts are really binding or actually are even solid in many countries. Pakistan is not excluded. So I think it's revisiting the kind of social contract that a country has is going to be important. The healthcare system in Pakistan is predominantly in the private sector. Over 2/3 of expenditure goes to the private sector. It's not highly regulated. And the public sector focuses on the most marginalized groups. So how to improve for that community, I think, is going to be key. Maybe one last point, which is not related to the question. I think the silent health crisis that Pakistan faces actually is family planning. Unless population growth is managed, it's linked to malnutrition, it's linked to maternal health, it's linked to all sorts of different things. Unless Pakistan faces this crisis, which is long-term, silent, I think all of the other issues you're facing will not be addressed, because there's no way you're able to manage the climate crisis you're facing, the economic crisis you're facing, unless this issue over the next decade is addressed. This is a fundamental issue which is not spoken about. So it's not one eye closed, it's actually both eyes closed on this issue. And I think that is going to be fundamental.
Yeah. Thank you, Abdullah. Again, this is very useful summary of I think what we should be thinking ahead. So just I think we are probably keeping well with the time, and that was my promise with Secretary Saab as well. So I think just to sum it up, as I gather, we clearly see an emerging consensus on firstly the need to urgently upbuild the national and global capacities in all areas having implication on health security, and this encompasses a resilient health system, and also not to forget thinking about the population control and family planning all the time as part and parcel of the essential health services. Then we also, I think, clearly see an opportunity to build on the extraordinary work that the states and nations have done, along with international partners during COVID pandemic, to put in place a strong and resilient health system that we all want to have. As we have demonstrated in COVID, surely by working together we can make it in future as well. Then we also, I think, feel it's imperative to carry out this GHS agenda forward with a collective sense of responsibility among the health and non-health stakeholders. And when you look at the state level, considering the interdependency on each other, it is also critical to further enhance the coordination and collaboration among states as well as in the partners to again benefit from the collective strengths that they all bring in. And I think again in summary what is emerging out of the discussions in this particular session, we are all encouraged by the level of the sensitization which exists around the issue of I think all three components of detect, and respond as well. We also see a very, again, high level of seriousness now being accorded to the global health security. But considering the urgency and the sort of expectancy in terms of the next challenge like COVID pandemic, perhaps the pace is a bit slow. So I think probably the momentum that has to be raised. So I think that's how I would like to sort of conclude this session. Again, a big thanks to all our presenters for their very, very valuable and thoughtful experience sharing. Thanks to all the colleagues, excellencies, my friends, ladies and gentlemen, for your interest as well. I hope you all found it very, very useful. Now, I think as per plan, we are supposed to break for the tea. But before we actually do that, may I request Mr. Abdullah to actually hand over an official copy of the assessment that you have to the Minister, Minister Saab? Yeah. Minister Saab, if you can come to the stage as well. Thank you. Okay. Excellent. Well done. Excellent. Thank you. Thank you. Thank you. Thank you so much. Thank you very much. So thank you, Abdullah. Thank you, Minister Saab. But I am told that there's going to be no tea break. So we are going to continue with the next session. So please keep on sticking to your seats. Thank you. Thank you so much.
Assalamualaikum. See, this is an announcement for the people. thematic area is Dr. Saima Shafiq. Dr. Shafiq is an environmentalist and a climate change expert working as a director with the Ministry of Climate Change. With over 13 years of extensive experience, she has vitally contributed to the development of the National Climate Change Policy and more recently to the National Adaptation Plan of Pakistan. I'd request Dr. Saima to please take the session forward by introducing the esteemed speakers while also spelling out the respective sub-themes of the session. Please, Dr. Saima.
Thank you, Afifa, and thanks to Ministry of Health for an extensive and more meaningful collaboration with Ministry of Climate Change to undertake this important session. Very briefly, we will move on towards the speakers of our session. It's a hybrid kind of session in which few of our speakers are online and few of our speakers are here in person. So I would like to welcome them and introduce them very briefly and ask them to be seated on the stage, whoever is available in person. So my first speaker of the session is Ms. Alicia Rosero. She is the public health expert and has an over 20 years of experience. And currently she is working as a project director for JPIGO's project, Enhancing Global Health Security Initiative, which is funded by the Center for Disease Control. So thank you, Ms. Alicia, for joining us. She has also done her master's in public health from Columbia University and currently based in South Africa. So welcome to Ms. Alicia. Our next panelist and speaker is Dr. Anne Wilson. Dr. Anne Wilson has a degree in medicine from Queen's University, UK. And she has a very extensive experience of almost 25 years, in which 10 years are purely from clinical services. And she has an extensive experience in public health and communicable disease control. And she's currently working with GHSA on a project on global health security, IHR strengthening. So welcome to Ms. N. Our third speaker and a panelist is Mr. Asif Sahibzada. Asif Sahibzada is currently working as DG Environment and Climate Change with Ministry of Climate Change and Environmental Coordination. He has an extensive experience of working with government sector, both in environment, forestry, as well as climate change. He has contributed extensively to National Climate Change Policy 2021 and Nationally Determined Contributions 2021, that is policy instrument by the government of Pakistan submitted to UNFCCC. So he has an extensive background of both climate change and environment. Thank you, Asif Sahibzada Sahab, for joining us here. Now I would like to introduce our speakers who are available online. So I would request IT team to check one by one that all of them are available and connected. So our first speaker is George Lee. He is again a public health consultant working as Deputy Director for Global Health Advisory and Science Partnership Team. And he has also an extensive experience of working in the sector from the last 18 years. So welcome to George Lee. Then we have Sanjay Vijaskra. Pardon me if I'm pronouncing your name very wrongly, Sanjay. So we know each other. We have an acquaintance in the past with myself working with Sanjay because he has an extensive portfolio with UNICEF. He has worked a lot in water sanitation and hygiene sector, both in emergency and development. And currently he is leading a program of UNICEF and heading almost 8 countries. And Pakistan is one of the country in his working domain. So welcome to Sanjay. And our last speaker, but not the least, Mr. Urva. Urva has an extensive background of working purely in climate change related intervention. He is currently working on first ever capacity building program on Article 6. Article 6 is basically the article of Paris Agreement. So he is working extensively on the capacity building of both federal and provincial governments for the carbon markets. So Urva is also here with us online. He is currently with UN Environment Copenhagen Center based in Copenhagen. So welcome to Urva as well. There is one more panelist. We are expecting that he will be here online soon. He is Arshad Samad Khan, the National Adaptation Plan Program Advisor with Ministry of Climate Change. So we would like to have some insightful inputs from him on Health National Adaptation Plan as well. So I'm hoping that Nadia will be able to connect him soon because we really want that all the inputs are here available to our audience from both our in-person as well as online panelists. Now, moving on to the actual session, the session is being designed in a hybrid fashion. Although with the flow of program, we were expected to have first presentation from George, but we have a kind of an urgency from our DG Environment and Climate Change because Secretary Saab has delegated him with the responsibility to be here in person to deliver the first speech or kind of a keynote. So I would request Asif Sahibzada because he has a time constraint. So Asif Saab, looking forward to you to give us a policy perspective that is though the fourth in the slot, but we would like to give you the opportunity to start. Thank you.
Thank you. On behalf of the Ministry of Climate Change and Environmental Coordination, I thank all of you and the organizing ministry, the Ministry of Health, the Honorable Minister Health, the worthy Secretary Health, and the distinguished participants and development partners for inviting us to participate and have a speech with you that how climate change and health are interlinked. I'll rely on my written notes which on behalf of the ministry. This Global Health Summit is truly a very important event that how the link between the climate change and health can be established and how the climate change is impacting the health. So I extend my heartfelt gratitude for the opportunity to participate in such a distinguished gathering of leaders and experts in the field. This summit serves as a pivotal platform where innovative ideas, groundbreaking research, and collaborative efforts converge to address the critical challenges and opportunities in global health. Ladies and gentlemen, the global health security is the collective effort to manage cross-border health threats such as COVID-19 by the international communities. With regard to climate change, it is linked to evolving public health threats as environmental shifts creates a complex and dynamic relationship that can amplify existing health risks and give rise to new challenges. We all know that extreme weather events can lead to vector-borne diseases such as malaria, dengue, Lyme, food and water security, crop failures, and food shortages causing malnutrition. air pollution and respiratory diseases, cardiovascular problems, and displacement and migration. We can realize the gravity of 2015 heat wave in Karachi, which resulted in over 1,200 deaths. Air pollution also contributes to approximately 60,000 premature deaths in Pakistan annually. This is the data which WHO has shared with us. Addressing the intersection of climate change and emerging public health threats requires comprehensive strategies that integrate environmental and health considerations. Ladies and gentlemen, the public health interventions, such as those being addressed in this Global Health Security Summit, should be designed with a holistic understanding between environmental sustainability and human health. As Dr. Saima Shafiq has highlighted that we have updated our NDCs in 2021 and submitted to the UNFCCC. It highlights the NDCs, the Pakistan updated NDCs highlights health is one of the sector prioritized by the Ministry of Climate Change and Environmental Coordination to be included in, is included in climate change adaptation, the National Adaptation Plan and Mitigation Agenda. National Climate Change Policy, it's also been updated in 2021, also proposes various policy measures to address the impact of climate change on human health. That includes building capacities of vulnerable communities, ensure that incorporating health-related climate change issues into national health plans, inform, sensitize, educate, and train health personnel and the public about climate change-related issues, health issues. Furthermore, the ministry, during the recently held COP28 in Dubai, also, along with 123 countries, we have signed a new declaration, COP28 UAE Declaration on Climate and Health, to recognize the linkage between climate change and public health. This new declaration seeks policy interventions to build more climate-resilient health systems, cross-sectoral collaboration to reduce emissions, maximize the health benefits of climate actions, and increase finance for climate and health solutions. Ladies and gentlemen, in the end, I express gratitude to the participant for all the participant for their commitment to global health security. Addressing these challenges requires a multidisciplinary approach, combining efforts from environmental scientists, healthcare professionals, policymakers, and communities. Thank you for your listening. Thank you, sir.
Thank you, Asif Sahibzada Saab, for highlighting all the major aspects. Definitely, health is one of the major area through which the communities thrive if the community's health is safeguarded. Unfortunately, with increasing climate change impacts, health is one of the most vulnerable sector that has emerged, and it has emerged as a challenge that needs to be overcome by the governments through effective governance model as well as strengthening the health systems. As DG Environment and Climate Change has already highlighted that there are 2021 by Government of Pakistan, and it's under the scope and mandate of Ministry of Climate Change. One of them is NDCs 2021, and the other one is NCCP, that is National Climate Change Policy 2021. Both of these documents have emphasized with clear-cut recommendations, policy recommendations for climate change and health. So, and specifically under NDCs, health in all policies has been further emphasized so that it gives kind of a promotive platform for One Health approach as well. Now moving on to hear from our one of the esteemed speaker, Jo. George Lee on the synergies between climate change and health sector at regional level. So it's George Lee or Miss Anne, they will be presenting. So over to Dr. Anne.
Assalamu alaikum. Assalamu alaikum, and please don't worry, audience, I'm not going to speak again. My job here is to introduce my public health consultant colleague, George, who's online, who unfortunately was unable to join us physically and come to Pakistan. He's very disappointed in that, but hopefully on another day he will come. So George is a public health consultant. I work with him in global operations in the UK Health Security Agency. And the work that I do, as we heard earlier, is about response and pandemic preparedness and outbreak, not specifically under the heading of climate change, although the work I do and our project does is about climate impact. So George is a public health consultant and a deputy director within our organisation in global operations and heads up a team in global health advisory and science. He has 18 years as a civil servant, and he was previously deputy to the Director of Health Protection in our last organisation, Public Health England, and he, prior to that, was a Director of Public Health in London in Tower Hamlets. So George has a lot of experience in public health. So in relation to what George is going to talk about, if I tee it up for you, the new organisation, the UK Health Security Agency, came about during the COVID pandemic. And there were a lot of challenges in relation to a new organisation being designed at the same time as a pandemic. However, there were also many opportunities. And one of the opportunities with the creation of the new organisation was that there was an opportunity now to address some of the threats to public health that previously hadn't had as much attention and exposure. Climate change was one of those. Our Chief Executive, Dame Jenny Harries, who was here last August, and our Chief Scientific Officer, they both agreed that the health effects of climate change and the adaptation to it was a long-term threat to public health. And so the idea of creating a centre for climate change within the organisation came about. However, as George will now tell you, the case for a centre and why would we have a centre to address these issues still had to be made so that the public health response to climate change could actually be embedded in the organisation. So we are still working through some of that, but I will now hand over to George, hopefully who will share his screen. I think the slides might work that way, and if they don't, then we'll try something else. But George is going to spend a few minutes talking about our story in relation to the Climate Centre in UKHSA.
Thank you, Anne. Hopefully you can hear me. I'm sharing my screen from my end here, but can you not see it over there?
We can. We can.
Yeah, we can see.
Oh, you can see. Thank you. Just to build on what Anne said, apologies that I cannot be there in person. And I'd also like to convey Lee Barang-Ford's apologies for not being able to present today as well. She also would love to have been there. I think I just want to start with really describing the threat that we're all facing. And essentially the world is on track for around 2 to 3 degrees Celsius warming, and that has a number of potential impacts on health and an increase in the risk of several hazards for us all. Some of those are the increases in vector-borne diseases, heat-related illnesses, climate-related migration. And I think very importantly at the bottom there of the bullets is actually these things can combine and create compound and cascading risks together and create even greater crises. So climate change is now a major context from which UKHSA really now needs to protect the health of our population from a range of hazards that are climate sensitive. just to take you to the centre, we launched it in October 2022, and I think it's important to, and building on what Anne said, that was 12 to 18 months after the idea and proposal for a centre came along. What our significant role is really is to be able to build the evidence base and the science, but actually what's really important is how we mobilise that science and how we mobilise that evidence to inform policy and action, and I will take you through some parts of how we're doing that. But one of the important things that we have here is being pragmatic and practical. We often feel that people feel a paralysis around being able to act on climate change, and actually we want to say to people there are things we can do. It isn't all doom and gloom, and so we want to help decision makers. This is where we feel we're important, to understand the trade-offs and synergies, to maximise health outcomes and minimise bad health outcomes. In order to do that, our advice needs to be people-centred and focused on people's experience. Technically, we need to be providing a range of scenarios and assessments of those scenarios in order to communicate what the possible futures might look like and how decision makers can make decisions. And I think part of that is about how we maintain optimism, because I think we must keep faith that we can actually do something about climate change and its effects on health. From the centre's point of view, in order to be able to act on this, we needed a vision, and we also needed to be seen and be a part of as a strategic priority for the organisation for UK Health Security Agency. I won't go through this, a very detailed slide, and we will share these, but just to pick out a couple of things. We're in the business of being prepared for what's going to come from climate change, and particularly how we do vector surveillance and how we develop early warning systems. We also need to respond as and when it needs to, and we need to develop what are the effective interventions and evidence what is effective to enable those interventions to be implemented at a range of places nationally and locally. And we also need to build our workforce and our capabilities and our capacities to be able to act on that response and to do the preparation. So that's where we're coming from within the organisation. But how do we make this work? Within the UK Health Security Agency, we have a hub and spoke model. Many people are interested in working on climate and health effects. It's the new, it's the new thing that everyone wants to be involved in. However, not everybody who can contribute is actually managed from within the centre. And to be effective, we have to be multidisciplinary and we have to be collaborative. We need to bring some of these disciplines together. We need to bring behavioural sciences together with the data and intelligence people. We need to bring environmental sciences with the modellers. And this is what we're trying to achieve by having ownership across the organisation, which I think is extremely important. However, I think what's also really important is how we develop our external partnerships and relationships. We mustn't overpromise. It's very easy to promise things and not achieve them. But what we need to work both across our own government, across the Foreign and Commonwealth Office, with the Environment Agency, with the Meteorological Office, but also actually with the other countries within the UK. We're a very England-based organisation. But we also need, if to have impact in effect, we have to have good relationships with local government, and so that they can trust us and understand what is effective and what actions they can take and we can support them with. But of course we also need to work with the non-governmental sectors as well. So just to finish, the key messages really are that we've developed this centre and it's took some time and it requires high level commitment. And it also takes quite a lot of hard work to get it organised and to get it operational. Long-term, high-quality partnerships are critical to future success, and that's really high on our agenda. I think crucially we must go beyond describing risk, and I think in public health we're very good at describing the problem but not necessarily articulating solutions. And what we need is to go beyond the risks, but we need to assess and model what intervention options there are and support decision makers in understanding what those options are and making good decisions. And from that perspective, that is how we feel we move from a sense of paralysis around climate change and health to actually doing practically and pragmatically something about it. I'll finish there. Thank you very much.
Thank you, George, and thank you, Anne, for such a wonderful presentation. I would like to just emphasize on that this is one of the most wonderful idea. We in Pakistan are currently initiating a process where we have been working in close collaboration with Ministry of Health to establish such kind of climate change and health strategic unit, and we are excited to know more and learn more from you on that, because that idea will be executed and implemented by WHO in support of Ministry of Health, and definitely Ministry of Climate Change will be one of the facilitating entity through GCF readiness program. So we are really looking forward to you for the next steps. Thank you. Now, moving on to the next presenter, I would like to just touch upon one of the core topic is climate change, public health threats, and what challenges, learning, and opportunities we have been arisen at the global level. We would like to hear from Ms. Alicia Rosero more about it. And thank you.
Let me see if this works. No, okay. Thank you, Dr. Saima. Thank you for organizing this panel, which is so critical to our times today. And thank you to the government of Pakistan also for hosting this, this event and gathering us all here today. Honorable ministers, esteemed guests and delegates, it's really my honor to be with you today in Islamabad and participate in these important discussions that affect us all profoundly, no matter where we are in the world. Today, I seek to address a matter of global significance that transcends our borders and demands our immediate attention, and that is the intersection of climate change and public health. Given the escalating trend in global average temperatures, climate health will increasingly hold greater significance for humanity over time. It is imperative for us to unite in forums like this, where we can deliberate on various scenarios, pool our collective knowledge, and engage in mutual learning. Through this collaborative process, we can strive to build consensus on potential actions that need to be taken. The year 2022 was the 6th warmest year on record, and this is based on 150 years of data. Strikingly, the 10 warmest years have unfolded since 2010, so with the most recent 9 years, that's between 2014 and 2022, consecutively standing out as the warmest in our historical record. And the forecasts indicate that this warming is likely to continue at this pace. Fueled by human activities such as deforestation, industrial emissions, and the burning of fossil fuels, climate change has ushered in a host of environmental changes, which we'll talk about. The surge in frequency and intensity of extreme weather events, including hurricanes, floods, wildfires, and heat waves, has become more than a mere environmental concern, as it directly impacts public health, leading to displacement, injuries, and loss of life. As we know, many of the worst impacts will be felt by those populations which are already suffering because of multiple health burdens and vulnerabilities combined with poverty and socioeconomic exclusion. These vulnerable populations face compounding challenges in accessing clean water, shelter, and medical. Altered climate patterns are further exacerbating the spread of vector-borne diseases, as we've heard about, such as cholera and typhoid. As I sit here today, I'm based in South Africa, and the Southern Africa region is facing multiple cholera outbreaks that we have not been able to contain for the last several months. In addition, mosquito-borne illnesses like malaria and dengue are expanding their susceptible to the impacts of climate change and the associated rise of vector-borne diseases. There are an estimated 35 million people at risk of malaria and 50 million people who are at risk of dengue fever. In 2019 alone, Pakistan reported over 50,000 cases of dengue, the highest number in the country's history. In neighboring Afghanistan, malaria is also a major public health concern, which we heard about this morning, with the country reporting a 45% increase in malaria cases between 2022 compared to 2021. This shared threat emphasizes the regional nature of these health concerns, warranting collaborative efforts to address and mitigate the impact on vulnerable populations. We witnessed how the devastating floods last year had far-reaching impacts, 2022, with the floods damaging crops, livestock, and infrastructure, leading to food insecurity, malnutrition, and enormous economic losses. The government of Pakistan and its partners have provided life-saving assistance to over 6.1 million flood-affected people in 34 districts. However, significant humanitarian needs persist, especially in flood-prone areas where some 3.4 million people out of the 9.5 million targeted remain unassisted. Air pollution, closely linked to both climate change and public health, is another critical concern. The burning of fossil fuels not only releases greenhouse gases, but also produces air pollutants causing respiratory disease, cardiovascular issues, and premature death. As temperatures rise, the concentration of ground-level ozone, a major component of smog, also increases, exacerbating these respiratory problems. And air quality indices in many countries continue to rise and underscore this phenomenon. For instance, in 2019 in New Delhi, they recorded an air quality index over 900, which is more than 11 times the safe limit set by the World Health Organization. The city was engulfed by a thick layer of smog, reducing visibility and causing breathing difficulties for millions of residents. The smog was attributed to many factors, and similarly in Lahore, Pakistan's second largest city, they faced a similar situation with an air quality index over 500, which is also considered hazardous. So the challenges posed by the intersection of climate change and public health are immense indeed, but we are continuing to face them head on, and in doing so, we have gained some very valuable insights. We've talked a lot today about the interconnectedness of our global community, and that is a crucial lesson. Climate change knows no borders, emphasizing the necessity for collaboration and shared responsibility for the well-being of humanity. The COVID-19 pandemic has also highlighted the importance of preparedness and resilience in the face of health crises, with lessons applicable to the broader context of climate change. So how can we start to think about possible and practical actions? The first step, we believe, is to identify and map vulnerability. This morning, actually, Dr. Brennan mentioned the STAR approach and vulnerability risk assessment mapping, which is one of the ways we can incorporate climate hazards into our health assessments. Because climate health impacts not all of us in the same way. We know that vulnerability to climate health related consequences will be influenced by our geography, our demographics, our biology and health status, the political and socioeconomic status in which we live, as well as the strength of our health systems. So, as I mentioned, climate-sensitive health risks are disproportionately felt by the most vulnerable and disadvantaged, including women, children, ethnic minorities, poor communities, migrants, displaced persons, and older populations, and those with underlying health conditions. People's climate vulnerability is also determined by their exposure to these threats, by their sensitivity, by their capacity to adapt and assess their assistance and services. We have a chance now, in the face of a global threat and in the wake of the COVID-19 pandemic that has taught us so much about response, resilience, and recovery, to truly reorient our health action and health service provision around the needs of the most vulnerable, whose multiple concurrent burdens and risks also contribute to the overall population vulnerabilities. As we confront these challenges, there are also opportunities to transform our healthcare systems through sustainable practices, investment in renewable energy, and integration of climate resilience into infrastructure in order to build a more robust and adaptive healthcare system. As we've heard, Dr. Saima, Pakistan is at the forefront of developing many of these policies and initiatives with the National Adaptation Plan as one example. But I want to also highlight examples from the region. In Bangladesh, a low-lying country that is highly vulnerable to sea level rise, flooding, and cyclones, the government has implemented initiatives such as constructing climate-resilient health facilities, development of early warning systems, training of healthcare workers on these systems, and the provision of mobile health services to respond rapidly. In Nepal, similarly, a mountainous country that is prone to landslides, avalanches, and glacial lake flooding, the government has taken steps to improve the climate resilience by establishing a climate health unit and integrating climate change into all their health policies and plans. Another important area is promoting public awareness and education through risk communication and community engagement, which will equip communities to adapt to these changing environmental conditions and protect against health threats and advocate for policies addressing both climate change and public health. Communities armed with knowledge are better prepared to navigate evolving environmental conditions, shielding them from health hazards and actively calling for responsive actions from their governments and leaders. The transformative impact of public awareness and education extends to behavioral changes that can curtail greenhouse gas emissions and contribute to the broader effort to mitigate climate change. As we convene to review our global health security agenda, we need to adequately plan for these climate-related threats, both at the global and country levels, and establish these resilient health systems that can prevent, detect, and respond to these threats. It is time that we integrate and ensure that core services, environmental sustainability, and climate resilience are central components of universal health coverage and primary healthcare systems. There is an opportunity to innovate and to introduce cheaper and reliable solutions, as well as mainstreaming climate resilience into the fabric of our health systems today. We will need to support research and innovation for climate-friendly, resilient tools, and we will also have to train and capacitate our workforce with the appropriate knowledge, competencies, and tools to face climate-related health problems. Not once-off trainings, but rolling out continuous support using after-action reviews, simulation exercises for simulating outbreaks and other health hazards are key to supporting continuous workforce development. Along with assessing country-level vulnerabilities and risk, collectively these components will need to be integrated in climate-informed surveillance systems and response plans as a crucial way forward. In conclusion, the challenges posed by the intersection of climate change and public health are indeed substantial, but they are not insurmountable. The lessons we've learned, particularly from the recent global crisis, have equipped us with the knowledge and tools to forge a path forward. As we confront these challenges, we must also recognize the opportunities for positive change, from transforming healthcare systems to fostering public awareness and driving innovation. As we strive to achieve the Sustainable Development Goals by 2030, it is incumbent upon us to act decisively and collaboratively. Our actions today will determine the world we leave for future generations. Let us seize this moment to build a healthier, more sustainable, and resilient planet for all. Thank you very much.
Thank you, Alicia, for very comprehensive points that you have highlighted. I would like to touch upon one thing that you have very intricately mentioned, that whenever we have to look at climate change and health impacts, we have to look at its two dimensions. One is environment and other is climate change. So we cannot we cannot close one eye and see the problem, but we have to open both the eyes to see both the dimensions, that how environmental degradation is contributing towards the climate change and how climate change is aggravating the environmental degradation. So this is kind of a vicious circle which we have to break. And thank you touching upon two international examples from Bangladesh and Nepal, and also highlighting and touching upon the climate risk vulnerability assessment, which is one of the policy recommendation for NCCP 2021 that came in both from the Health Ministry as well as the Climate Change Ministry. So we put it into our policy recommendation, and currently there are organizations who have started working on, like FCDO is working on climate risk vulnerability assessment for health sector in KPK, and WHO is also supporting one of the risk vulnerability assessment in health sector in other two provinces. GIZ is also picking up certain risk vulnerability assessment with the focus of the districts. So it's heartening to see that what is in policy recommendation is moving forward, though it's a little debate that how fast we are moving towards the target. But yes, there is some progress going on. So it's really insightful to listen from you as well. Now, moving on to our next presenter, whenever we are talking about climate change and climate change implementation agenda, we cannot skip the two approaches. One is the adaptation and other is mitigation. So let's hear from Urva on climate health nexus, mitigation and adaptive measures for strengthening the health system. So over to Urva. Urva has joined us online.
Thank you so much, Dr. Saima. I hope I'm clear to all of you. Yes. I'll just start by thanking to all of the participants and Dr. Saima for moderating this session. Joining you virtually from Copenhagen, Denmark, a city renowned for its commitment to sustainability and health, I'm reminded of the global nature of our mission. Today at this summit, we stand united across continents, time zones, and cultures, bound by our shared pursuit of addressing one of the most pressing challenges of our era, the intricate and undeniable nexus between climate and health. So our dialogue today transcends geographical boundaries, reflecting the universal impact of this nexus, a reality that is profoundly evident in countries like Pakistan. In Pakistan's diverse landscape, from Himalayan peaks to the arid plains, the impact of climate change are not mere forecast, but current realities altering the health and well-being of millions. When we talk about the health systems, which are the foundation for the individual and community level resilience, the services they provide are often regarded as a first line of defense in preventing adverse health outcomes and protecting all global citizens by serving as a critical structure that provides accessible, affordable, accountable, and reliable healthcare and public health services. The context in which healthcare and public health services are delivered and consumed must also adapt to meet immediate and future challenges. If you just read about the 2021 Lancet Countdown report, which described climate change as the largest global health threat of the 21st century, further underscoring the impact of the climate change, which is a public health emergency, while also recognizing the opportunities that exist to redefine our perspectives and approaches at this critical juncture. Yet practitioners often disregard the breadth and severity of impacts that climate change can have on the performance and sustainability of the health system and its ability to ensure health security. Better integration of climate information in health system planning is essential to ensure that health systems remain resilient to adequately serve their populations while reducing health security risk. Talking about the climate impacts on health systems, it's important to understand that the impact of climate change and variability threaten the sustainability of the health system performance and development goals through increased pressure from rising heat, extreme weather events, changes in precipitation patterns, shifts in duration and prevalence of diseases, and increased potential for the emergence of novel diseases. So between 2030 and 2050, climate change is expected to cause approximately 250,000 additional deaths per year from malnutrition, malaria, diarrhea, and heat stress, according to the World Bank report, which predicts internal climate migrants may total 216 million by 2050. Intensified and frequent extreme weather events can halt or hinder access to availability and quality of care for the patients and providers, which can result in substantial resource losses, for example, financial, human material for health systems. So forest fires can also lead to facility destruction or extend closure for the cleanup. The intertwined relationships between environment, climate change, and variability, human health, and health systems are further exemplified by climate-sensitive diseases. Malaria, dengue, and many foodborne and waterborne diseases are rising at an alarming rate and expanding in geographic range due to the changes in seasonality, increasing temperature and precipitation, deforestation, and air pollution. Endemic infectious diseases and novel disease outbreaks will likely worsen as shifts in climate create favorable conditions for disease vectors or pathogens to proliferate, leading to backslide in health gain. So multiple climate hazards can occur simultaneously while non-climatic risks also interact, which compounds the overall risk for all the sectors. Lessons learned from the COVID-19 continue to highlight the importance of ensuring strong and resilient health systems by integrating health security while also ensuring access to essential services. As the effects of climate change and variability become more substantial at both individual and population levels, health systems need to better integrate climate risk management to ensure that shocks and stressors are addressed to prevent losses in development and health gains. When we talk about the strengthening health systems to tackle the climate crisis and ensure health security, as per the 6th Intergovernmental Panel on Climate Change report, remarked that future human vulnerability will continue to concentrate where the capacities of local, municipal, and national governments, communities, and the private sector are least able to provide infrastructure and basic services. So addressing current gaps and improving health system performance without considering the effects of climate change and variability is simply not enough to prepare a health system to tackle the effects of the climate crisis and ensure health security. So health systems should take steps to understand how climate change will affect their ability to finance, manage, protect population and individual health, evaluate the effectiveness of their interventions and systems under the diverse climatic conditions and mediated impacts, and identify opportunities to enhance institutional iterative risk management capacity across all levels. And this requires a strategic approach and is dependent on the commitment of the health system to work across sectors, fostering multi-sectoral and community engagement to achieve shared objectives that enhance access to essential services and public health functions. Timely, context-specific, and cross-cutting investment in health system must leverage and improve existing capacities and institutionalize risk management capacity across public and private institutions and community structures while exploring short and long-term opportunities to strengthen the resilience. The conclusion of my talk, as climate change becomes more apparent, while countries are still struggling from the recent natural crisis, it is clear that failing to prepare for and address strains on the health system will lead to long-term secondary impacts that make it harder for the system to recover and perform optimally. So investing in health system strengthening is one way to mitigate the adverse effects of climate change and infectious diseases threats on population and individual health. Health system strengthening efforts should include climate and health security considerations by promoting and strengthening capacity for effective and iterative risk management across all levels, fostering multi-sectoral and community engagement, and identifying short and long-term actions and investments to increase system resilience. So this involves involves encouraging policymakers and practitioners to identify opportunities to operationalize their climate and health plans down to the lowest levels, leverage routine information, climate services, and surveillance data to support informed decision-making to optimize resource use and ensure primary healthcare and health system response plans are tailored to the local context and needs, which will allow for greater adaptability to address emerging challenges. As we bring today's summit to a close after 30 minutes from now, a relevant proverb comes to my mind. Many hands make light work. So joining you far away from Copenhagen, a city at the forefront of health innovation. So this proverb resonates deeply with our shared mission. Today, we have united hands across the globe tackling the intricate climate health nexus. This summit is not an endpoint, but a powerful beginning, a testament to what we can achieve together for global health and sustainability. Thank you all for joining. Thank you.
Thank you, Urva, for touching upon IPCC's 6th report and its outcome for the climate change and health. From climate change and health perspective, and its more emphasis on strengthening the system and obviously working at the local approaches and not at all levels. And thank you for motivating us with the last conclusion. So now moving on, we cannot, whenever we talk about the climate change, we cannot leave children. Children are at the center of all climate change. Climate change impacts, may it be the health sector, may it be the any of the sector. So looking forward to Sanjay Vijayaskra for his intervention. So Sanjay, if you are online, please start your session, start your input.
Thank you. Thank you, Saima, and distinguished delegates and colleagues. Thank you very much for organizing this this really important event. Particular thanks, of course, to the government of Pakistan and all the partners, and thanks for the opportunity to address the Health Security Summit. It's no secret to any of us that climate change threatens the lives, health, and well-being of children. But what many people don't appreciate is the urgency as well as the sheer scope and scale of the threat. UNICEF's 2021 Children and Climate Risk Report, which had an index that measures exposure and vulnerability of children specifically, found that 1 billion children are at extremely high risk of the impacts of the climate crisis. Children's developing bodies and minds are deeply vulnerable to the dangers, and of course those living in low-income communities are most exposed to the risks. And while I was myself visiting Pakistan in November, just less than 2 months ago, I visited some of our programs with communities affected by the devastating floods in 2022. And these communities are still rebuilding more than 1 year on. And when I was there, I met young Aslan Ahmed, a very smart 7-year-old boy from a poor family living in a remote village of Mirpur Kash district in Sindh province. And Aslan was my guide, and he really did surprise me with his knowledge and very clear explanations and understanding, certainly of the impacts, but even of some of the kind of more structural causes of these impacts. And he showed me a school and so wash facilities in a school that we had worked on, UNICEF and partners, and explained how he and his schoolmates were, of course, using these facilities, but also using them as a learning opportunity and as an opportunity to for others and other children to learn around not just health and hygiene, but also how infrastructure and systems can be kind of more resilient to future shocks like flooding. So there are millions of children like Aslan, and yet their voices have either been ignored or largely disregarded in the climate change discourse. Not to mention kind of financing prioritization. So the dangers of climate change are hitting children from all sides. And for one, an increase in extreme heat has detrimental effects on all of us, but of course, infants and young children particularly. And again, as mentioned, they're less able to regulate their body temperature and more prone to dehydration. And extreme heat can also lead to increased mental health problems, increased post-traumatic stress disorder within children and adolescents. So with increased temperatures comes also increased risk of communicable disease. We've heard about that, malaria and dengue, as well as those other diseases that may not even be endemic. And of course, related to that, high temperatures allow deadly pathogens to thrive in fresh water, and already more than 1,000 children under 5 die every day from diseases arising from lack of water sanitation and hygiene. Childhood diseases overall are spreading more because of climate change-induced environmental degradation. And flooding, of course, damages infrastructure, of course, contaminating water supplies, but also other important infrastructure such as health and education infrastructure. And of course, climate change has a big impact on children's nutrition, on everyone's nutrition, and particularly children's nutrition. With higher temperatures, increased rainfall intensity, greater variability in weather, crops are, of course, more likely to fail, and the impacts this has on food prices means that one of the early casualties and one of the most casualties with the greatest adverse impacts on health, of course, the diversity of children's diets. So this food insecurity is predicted to increase as the climate crisis worsens. And on education, about 40 million children have had their education disrupted every year because of disasters exacerbated by climate change, and this number continues to increase. So climate shocks disrupt children's education both directly as well as indirectly, because of course extreme weather can damage school education infrastructure, but also impact the health of children and keep them out of school. And of course there's the issue of displacement. According to UNHCR, extreme weather events are already causing more than 20 million people to leave their homes and move to other areas in their countries each year. So they are being internally displaced, and this, of course, has a large proportion of women and children associated with these displacements. Storms and flooding accounted for about 95% of the 43 million recorded child displacements between 2016 and 2021. And of course, climate hazards can have proportionate impacts on girls. Loss of livelihoods, displacement and migration from climate-related events often put girls in precarious positions. And of course, the consequences are gender-based violence, harmful practices such as child marriage, of course, are associated and can be associated with certain extreme weather events and disasters. And while no country is immune to the impacts of climate change, Pakistan's frequent exposure to natural hazards and the significant dependence on monsoon rain, the kind of glacier-fed Indus Basin waters make it particularly vulnerable. And that vulnerability is, of course, heightened through economic and social and economic impacts as well. And I'm aware of the Ministry of Climate Change and Environmental Coordination study that shows that the total annual economic cost of climate change to Pakistan ranges between something like 1.3 billion to 1.87 billion US dollars equivalent, or equivalent to 0.46 to 0.66% of GDP. So that is significant impacts. So to ensure that children like Aslan have a bright future going forwards, effective integration of children's needs and rights into climate policy is essential. And of course, we look forward to continuing to partner with the government of Pakistan to ensure this kind of integration of climate change and environment into broader health policies and strategies and guidelines. And the government of Pakistan must, of course, continue to build on the climate resilient and green initiatives in basic social services, including issues that, of course, the government is already working on and we're privileged to partner on, such as the solarization of health infrastructure, oxygen plants, and of course, schools and wash facilities that I mentioned earlier. But we must also strengthen young people's engagement and mobilization for climate awareness and, of course, climate action. And it must improve, and we must improve the preparedness for climate change-related disasters, including early warning systems, the resilience of communities, and pre-positioning of supplies. Again, we have very good experience from Pakistan and the rest of the region. And again, to acknowledge the government of Pakistan's leadership on climate action by establishing dedicated structures like the Ministry of Climate Change and Environment Coordination, as well as the National Disaster Management Authority and the Provincial Disaster Management Authorities. This lays a really strong institutional foundation to deal with climate change and disaster response. Finally, in 2023, the world took a critical step forward when the UN Committee on the Rights of the Child published what is known as General Comment 26, which provides guidance to states on what they must do to uphold and protect children's rights, children's right to a clean, healthy, and sustainable environment, both now and in the future. And that clarifies what the right is and what needs to be done. And if states fail to act, they can be held accountable for environmental damage and climate change occurring both within and beyond their borders. And as a very early signatory to the Child Rights Convention, I know the government of Pakistan takes its obligations in this regard very seriously, as do many other governments across the world. And we need to keep up the momentum on climate action and uphold the global and national commitments on this issue. So for many children like Aslan, whose future is at risk because of climate change, and for the 1 billion more of the world's children who are at extremely high risk, we really need to work together and act now. So with that, thank you very much, and back to you, Saima.
Thank you, Sanjay, for highlighting the vulnerabilities that are being faced by the children because of the climate change. And definitely climate change and health impacts are disproportionately affecting to those who are most vulnerable. Either they are children, or it's an elderly population, or someone living in far-flung areas, increasing their vulnerability because of their geographic positioning, or at times when there are situations in which the population has to move. The biggest impact is on women and children. So thank you very much for highlighting all that, and thank you also for highlighting that how the government of Pakistan has taken some leadership steps in identifying the climate change and health impact specifically in the context of children. And I cannot thank you more that the study which you have talked about is being supported and facilitated by UNICEF to Ministry of Climate Change now. But now the thing is that whenever we are talking about averting the impacts, talking about the concrete action, it is the Ministry of Health and health departments that are at the center stage, and they are the one that requires and need the support not only from our development sector partners, development sector banks, to other coordinating ministries, as well as leveraging the funding and resources for the health sector to strengthen the health system and also contribute at the on ground to avert the situation for the population, because we all understand, but at times the climate change impacts, most of the time the impacts that is being brought in because of the climate change are not in our control. In our control is only two approaches. One is mitigation and other is adaptation. Countries like Pakistan will be investing more on adaptation aspects. So thank you very much for highlighting that. Now I'm looking forward to Nadia. Nadia, from the time check point of view, do we have a time slot available for question answer session? Yeah. So thank you. Now moving on to our question answer session, I would like to touch upon to George and Dr. Ann first for a question related to One Health approach. We are looking forward that how in the context of health regulations, the One Health approach preparedness response to climate-related health threats can be brought in or can be activated. So if you can have some insightful thoughts on that, you or George, whosoever wants to respond.
Well, I'll open it up and then pass to George if he's still online, hopefully. In terms of One Health, sometimes I think we talk about it in a way that makes it very narrow. Public health is One Health in everything we do. So you can't do climate change or mitigation or the interface without talking about One Health. So all the sectors that we normally talk about in One Health have to be involved going forward. But George, maybe that's one of our internal partners, or externally we've been looking in terms of our centre. Do you want to say anything?
Just very briefly, we've not been an expert on One Health, all the regulations, but I think, as you said, Anne, the complex health challenges we're facing necessitate much greater levels of multisectoral communication, coordination, collaboration, both at national and global level. And in fact, I think there's a great example in Pakistan of the One Health Alliance objective is to improve multisectoral collaboration on new and emerging infectious agents. So I think it's absolutely vital that we do this and take a One Health approach. I think sometimes it can be quite difficult for people to really comprehend the nature of what that means in terms of the whole breadth, not just animal health, but environmental health as well. So we certainly think the newly published quadripartite National Implementation Guide for Joint Action Plans would be a really good place for people to start as well.
Thank you, George.
And I'm afraid I will have to leave, I'm afraid, now, but thank you very much for allowing me to come and speak. Thank you very much.
Thank you, George. Your inputs were very relevant and insightful for all of us. Now moving over to the next question to Ms. Arishe. So I would like to touch upon that there are many obstacles and complexities that are being arised because of the interconnectedness of health and climate change. So within the healthcare framework, do you have any insights and inputs for the Ministry of Health or for the government of Pakistan in the context of your international experience?
Thanks so much. Yeah, I mean, we talked a lot about the complexities of climate change and its impact on public health threats, such as the emergence of new pathogens. And we were really tested, for example, with COVID-19 in terms of a multi-sectoral, rapid, agile response to what was happening. Health equity is also something that I think we need to continue to work on, as we talked about the mapping of vulnerability, doing vulnerability assessments, and really identifying how we can sometimes pivot from the traditional healthcare structures to support more differential services and establish climate resilient health systems. I think another thing that I didn't talk about, but we heard a lot earlier from the previous panel, was on the importance of data. And as we start to work across sectors, the importance of data interoperability, looking across ministries, across sectors, becomes ever more important, and harnessing that data to then make timely decisions. But that then needs to be done with and in collaboration with multiple partners. And I think Anne's question earlier about how do we do that by bringing people together and really thinking about how we define collaboration within our country context is still something that we can further explore and strengthen. So maybe I'll stop there.
Thank you, Arisha. This brings in to close of our question answer session. If there is a question from the audience side, we are ready to take it. From Ministry of Climate Change, I am also one of the representatives, so I will take the cap of MOCC along with Asif Sahibzada. So if there is any question from the audience side, we are ready to respond.
Address the, this is Shahbaz from Japaigo. My question is, what is holistic approach regarding government institution to address the emerging challenges, particularly in aspect of climate change and other One Health and AMR challenges?
I think partly the question belongs to Ministry of Climate Change and partly it's to the Health Ministry. So from Health Ministry side, the representative will respond, but from Ministry of Climate Change, I would like to emphasize upon, with the permission of Asif Sahibzada, because he is the DG Environment and Climate Change, he will add on if I'm missing something. Like from the ministry side, we have emphasized through the policy recommendations, both in NCCP 2021 and NDCs 2021, that the kind of recommendations that are required to include this One Health approach within our policy, and also collaborate with Ministry of Health on its implementation as well. Like climate risk vulnerability assessments were part of that policy recommendation. Health safety, sanitation safety plans, water safety plans were part of that policy recommendation. So there are certain interventions that are being taken up, but that does not mean that everything is covered, but part of the things are being covered.
Thank you for this question. In addition, let me highlight that the Climate Change Ministry has formulated, it's a policy making body. It's formulated its Pakistan Clean Air Policy, Pakistan Hazardous Waste Management Policy, and the National Adaptation Plan. All have some addresses of the health. So in collaboration and coordination with the stakeholder, the health ministry, we are, the ministry is in the process that how we can make the health system resilient. So this is the.
Thank you, Asif Sahibzada, for highlighting few more policies that are also contributing towards the health sector. But definitely the key implementers are at the provincial level as far as Ministry of Climate Change is concerned. And climate change itself is a thematic area, is a theme that covers almost 12 sub-thematic areas. So all the ministries are working in collaboration under that National Climate Change Policy as well. Afifa?
Okay. Sorry. Hi, Dr. Mohammed Sartaj, country lead for UK Health Security Agency in Pakistan. My question is in continuity of, I think, the previous question. And this was discussed, I think, even in the previous panel, that while there are quite comprehensive policies and strategies, I'll be quite keen to hear your views on the implementation of it and the monitoring of its implementations, governance and coordination, which I think is really critical beyond making the policy and strategy, that how we take and monitor the action we recommended is basically implemented on ground.
Thank you. It's a very, very important question, that how the policy, the government makes policies, formulate policies, action plans, and how those are implemented. You know, at the federal level, the Ministry of Climate Change, we have formulated so many policies, the climate change policy, etc. But after the 18th constitutional amendment, you know, the implementation, most of the implementation, 90% rests with the provinces. I am glad to and happy to share with you that the provincial governments are in the process of formulating their own climate change policies. They have, the KP government has formulated, the Sindh government has formulated, the provincial government of Balochistan and this Punjab are in the process. They have also developed their action plans. So the action plans, if those are implemented, then the national priorities and the national policies are implemented in the sense. So this is the process which is being followed. In addition, I must say that the ministry is in the process that how it can, the capacity is a very, very crucial issue. Both at the federal level and at provincial level, we are in the process that how we can build our capacity to address the climatic changes issue both at the national and provincial level, and and how to address these to share these initiatives at the national level too. So this is the process which is being followed at the national and provincial level. Thank you.
Thank you for a chance to talk. I just wanted to acknowledge that this is a very thoughtful decision to include the climatic impact into the global health security system. So first, this is the acknowledgement that this is a wonderful idea, because climatic changes have a very, very drastic effect. If they are not addressed correctly, the health plans will go for 6. So this is a wonderful thing. Secondly, I want to acknowledge Annie that you had a wonderful presentation before and now also. I missed your part now, but my question was that you have so much of data collection, you have so much of experience personally being a doctor in African region, and you have been to the the devastation prone areas. So what would be your suggestion for a country like us, that how to go about formulating those integrated, collaborative, integrated plans for future based on your personal experience? One. Second is to the Dr. Sahab, the DG's, climatic change. What you suggest and what you are, professing is excellent. But what I see, Dr. Rizwan was sitting here, Dr. Rizwan, the DG 1122, Punjab. I am CEO of Sindh Integrated Emergency and Health Services. We have our own colleagues. But unfortunately, we haven't seen a platform before this where you, we, and all the stakeholders could sit together to identify that these challenges we can identify in tunnels, but all these tunnels getting together, integrated together on a platform where we can think of a futuristic action plan. You being a federal entity, you have to regulate and see that everything is aligned. But who is going to align them together, and how we go forward on that? Do you have a way forward on that? Can you comment on this, please?
Thank you. Thank you. This is another important question. Yes. As I said, let me reiterate that the forums like this and the responsibilities of the stakeholders at the federal and the provincial level lies with implementation. And let me please share my, as an environment specialist and environment professional, this decade is a decade of action. We have already spent 3 years, 21, 22, 23. We are in a 24. At the international fora and level, the countries like us and the international community wants us to deliver by 2030. And if we do not deliver, we all will suffer. Realize the gravity of floods in 2022. Realize the gravity of heat waves in 2015. Realize the gravity of others climatic problems and issues which we have faced. Today, in a meeting with the Senate Standing Committee on Climate Change, our Secretary Sahab has shared a very good example. That my son, I asked him that this is the most hot year. The 2023 was the most hot year on record in Pakistan. So his son, he shared a very good example that my son said that it was a very good year. And we have to face other years very hot. So if we don't implement, we don't act, we will suffer a lot. So this is the time that each and every entity, the stakeholder, whether it is federal or it is provincial, they should come up with some tangible outcomes, tangible action plans, and to implement those. So this is the...
Sir, my question exactly is the same. That you said that provinces and all should come. Like, who is going to create that platform where they should come to you or centrally?
Sir, as I said, the problem is not, the issue is not very complex now, because if you go to the to the 90s era, 90s, it was a boom of environmentalism, And then in 2000 up to 2010, again a boom. Now we are expecting that, and we are not expecting that, but each and every entity, both federal and provincial, they are realizing the fact and realizing that the climate change is real issue. And if this realization is intact, both at the federal and provincial level, and it is implemented, it is translated into action, then we will be in a position to address it. Very good. Thank you.
Thank you very much. I'll be brief. The first point you made actually is the key. The fact that we're talking about climate change under global health security, we need to join everything up. People, even some of my organizations, what are you doing talking about climate change? I said, no, I'm not. But public health, as we've said, has the impact of it, so it has to be joined up. So my experience in many countries has been that too often we as partners come with initiatives and it goes down a silo. And this is one of the things, and Dr. Safi's in the room here, I worked very closely with Dr. Safi, that we were very clear to join this up from IDSR in the beginning. So the committees and the implementation and all the plans are really important. But the last thing I would say in my public health experience, if you want a partner to continue to work with you, there are different ways you do. You legislate, but even legislation, they'll come to the meetings, they'll pay lip service, and they may leave. The way I will keep coming to these committees and multi-sector working is if I get something out of it. And it's not just the greater good, it's actually, I'm a very busy person. I have so much work to do. My bosses are chasing me, But if by what we do in the climate change and the committee, you actually help me do my job, I will keep coming back. In fact, I will be knocking on your door all the time. And that is the trick. And I believe that your committees and whatnot could get there in terms of individual organisations and sectors. They will want to come if they see it as helping them, not just individually, but in the work that they do in their sector. Thank you.
Thank you.
I am Dr. Abdur Rauf Janjua from, I have a little question and a suggestion. I am Dr. Abdur Rauf Janjua from the University of Azad Jammu and Kashmir, Muzaffarabad. Probably I am the one who is representing the academia in this summit, and I am the one who actually is attending this conference on my own because of my interest. But I feel there is a wonderful effort being implemented today, and this summit is of course a great opportunity for all the stakeholders to sit together for a future which is safe and which ensures their safety. But I think when we go for the implementation of all these policies, there is a very primary and very important sector which can play a very important role for the implementation of all these policies, and that is academia. You know, we have universities, we have colleges, we have students all over the country, and when we say we need to have the education on the mitigation of all these climate impacts and the adaptations of the nation, because as a nation this is the question of our survival. We have to plan and we have to execute and we have to put all our efforts together in order to ensure our survival. So we have exercised a number of community-related projects in Kashmir and in Pakistan, particularly on the control of infectious diseases. We have developed some very successful models of the integrated approach with the communities, with the academia, with the stakeholders, with NGOs. Unless we sit together, we all stakeholders, and particularly what I request all of this House is that the inclusion of academia in all of our policy making and in the implementation of policies, because we have almost 2 million youngsters in our universities who can act as the change agents, provided they are given the task and they are given the responsibility and they are given the place. So thank you.
Thank you. I think what you have highlighted cannot be ignored, and it's already under consideration, and part of the universities are playing their role in being one of the research partner with Ministry of Climate Change, I believe. So same is going good with the Ministry of Health as well. But this needs to be enhanced and increased, so the suggestion is well taken. This brings us to the closing of this session. Thanks to all the panelists who have joined in person and the panelists who have joined in online. We have the responses awaited from one of the panelists, but because of the time constraint, we cannot take that question, so we are holding that. So once again, thank you very much. And one last point, the response from the SIN was that there needs to be a platform, a coordinating platform. So that is again one of the need of the time, and there's a need to establish a climate change health platform which can be led by Ministry of Health and can be supported by Ministry of Climate Change to actually deal with such kind of interventions or requests or coordination. So definitely that is one point taken as a follow-up from this conversation and things. Thank you.
Madam, just to add regarding the sorry, I think it's too late, but just to add on what you have said, I'm Dr. Shaban Nadeem, and I'm working as Manager Operations CD and EPC Punjab at DG Health Office, Lahore. Just to add on what you have said regarding integration, the one thing which is missing for too long in One Health is a coordination and a sharing of the data, integration. And last week we have attended a meeting, and it was a breakthrough meeting, and NIH is taking lead under Ministry of Health for regarding establishing that National Data Health Center. So it will help a long way, I think, in a better data sharing, integration, and further evidence-based decision making and implementation. Thank you.
Thank you for your valuable comments. I think academia's comment and your comment is well taken. And let's close the session and move forward to the next follow-up event. Yeah, it's closing. Thank you.
So I think we have made you wait a bit too long, and we thank all of you for your participation until the very end, especially the ones who chose to stay. We thank you a lot. And I would like to formally close the session now. These were some fruitful discussions that went on. Inshallah, we would be meeting, we expect all of you to please meet us tomorrow at 9:30 a.m. sharp so that we can start in time and close in time. I thank you all for your participation, and I hope you rest out tonight. Thank you.